We will be discussing about the general physiology. I know your notebooks. Those of you who are having the my notes, जिनके पास में मेरे notes है, वो notes खोल लो. No need to make multiple notebooks. Okay, you just have to have a single notebook. That is why I have taken screenshots and I have put it in the rapid revision also, right? So those of you who are having my notes, that would be fine. जिनके पास नहीं है, those who are not having, they can use the workbook. उसमें थोड़ा font small है. I will give you the PDF है ना, शेयर कर दूंगा PDF, so you can watch it from there. Don't worry about that. So what is the sequence? Sequence will be same that we have studied. Like we will be discussing about the general physiology first, then we are going to discuss about the excretory system, GIT, endocrine, reproductive system, respiratory system, neuromuscular, cardiovascular, neurophysiology, and then we will end up with the miscellaneous things, right? This is going to be the scheme of class. These are my Instagram and Telegram in case if you want to connect with me for any doubts, right? So we will be starting off with the first thing. What is the first thing that we are having as the body fluids? I know नहीं दिख रहा है because I also have seen it just now. Print होने के बाद ही देखा तो नहीं दिख रहा है. I know it. Okay, just do one thing. अभी समझ लो. You guys, those of you, most of you are having my notes, है ना? जिनके पास में है, कितनों के पास में नहीं है? अच्छा, ये इतने लोग कहाँ से आ गए? ओके, नो इश्यूज, जस्ट गो थ्रू इट. मैं एक्सप्लेन कर रहा हूँ, जस्ट गो थ्रू इट. आफ्टर दैट आई विल बी सेंडिंग द PDF, तो PDF में से देख लेना, ठीक है? ओके, so we are having body fluids, and in body fluids we are going to have what? Compartments. We are having different compartments, right? So you already know total body water कितना होगा. How much is the total body water in a person? 60% of the total body weight will be the total body water. Suppose if I ask you 70 kg old man, male person is coming to you, how much is the water? 42 liters. Wonderful. 42 liters will be water. Now let's try to understand where this 42 liter will be in the body. ये 42 liter कहाँ पर होगा? Where it will be? It will be inside the cell. That is known as intracellular fluid. It can be outside the cell. That is known as extracellular fluid. Can be divided into how many compartments? Two. बोलो, जिनको पढ़ा दिया वो बोलो. How many compartments? Two. What are these two compartments? One is, sir, either it can be in the plasma. We are having blood will be having plasma, or either it can be present in the space. And so what is the interstitial space? The space between two cells is known as interstitial space. So what we have learned till now, we have learned total body water will be 60% of the body weight, and it can be present either inside the cell, either outside the cell. Outside the cell, sir, the two possibilities can be there. Either it can be inside the vessel, either it can be between the two cells. Okay, done with this? No issues with this? Right. Okay, now we will be discussing how much is the inside the cell. So that would be 28 liter. 28 liter will be inside the cell. Out of this 42, 28 will be inside the cell, and 14 liter will be outside the cell. Okay, now this 14 liter, now this 14 liter is further divided into two compartments. Either it can be intravascular fluid, that means it is in the blood vessel, that is going to be your 3 liter, and it can be your extravascular fluid also. It can be extravascular fluid also. Okay. Now, let's try to understand this. So this extravascular fluid is further divided into transcellular fluid. Transcellular fluid क्या हो गया? Transcellular fluids are those fluids which are present in the cavities. You are having multiple cavities. So first cavity you are having is cerebrospinal fluid, CSF, cerebrospinal fluid. That is also coming from. That is also coming from. That is also known as transcellular fluid. That is also known as transcellular fluids. You are having multiple cavities. What I want to convey, total body water कितना है? How much is the total body water? ये आवाज कहाँ से आ रही है? How much is the total body water? And out of that total body water, how much lies in your vessels, how much lies in your cells, and how much is in the transcellular cavities. Like we are having eyes. In eyes, we are having what? Which fluid is there? We are having aqueous humor. We are having aqueous humor in the eye. Aqueous humor, what is the function of aqueous humor? Just a moment. Just give me a moment. What is the function of this aqueous humor? Better now. Protection, support, nutrition, and support. Nutrition to what? Sir, lens and cornea are avascular structure. If they are avascular structure, they cannot get what blood from the vessels. They cannot get blood from the vessels. Just give me a minute. Okay, it's fine. Better, better now. All right. It is disturbing. Just give me a moment. I think better now. Okay. So this is going to be the total body water. This is going to be the total body water. Now we are having multiple cavities, right? We are having multiple cavities in the body, like we are having cavities for the eyes. We are having aqueous humor. If the levels of aqueous humor is more, which disease will occur? Glaucoma. We can have open angle glaucoma. We can have angle closure glaucoma, right? What about the blood? Okay, so this is going to be your intraocular fluid. Cerebrospinal fluid. Cerebrospinal fluid is formed from where? Ependymal cells, lateral ventricles, choroid plexus. So they are formed in choroid plexus, lateral ventricle, and the name of cells will be ependymal cells. Ependymal cells. Okay. Next we are having digestive juices. Total secretions in a day. How much is the total secretions in a day? Total secretion will be 9 liter. Out of that, 8.8 liter will be getting reabsorbed again. 200 ml will be going out into the stool. So stool will be having how much amount of fluid? 200 ml. That would be going out. Okay. The question they have asked you in your FMG examination, how much amount of saliva is secreted in a day? How much amount of saliva is secreted in a day? That would be 1.5 liter. If I ask you how much amount of HCl is secreted in a day? HCl 2.5 liter. Very good. 2.5 liter of HCl, 1.5 liter of saliva. What is the total urine output in a day? Average 1.5 to 2 liter approximately. That would be approximately 1 to 2 liter will be the urine output. Right? We are having serous fluid like intrapleural fluid. Okay, we are having pericardial fluid. We are also having peritoneal fluid. Synovial fluid is present in the joint. If there is loss of synovial fluid, what will happen to the joints? They will come closer. There will be reduction in the joint spaces. If there is reduction in the joint spaces, there will be friction. And if there will be friction, there will be a disease known as osteoarthritis. Osteoarthritis. Wonderful. Okay. There is fluid in the urinary tract. We will be discussing about that, how it is getting formed and how it will be transported. Okay. Then with this, the important one that we are having over here is blood. चलो मुझे फटाफट बता दो. First of all, what are the different components of blood? Blood will be having cells. How much is the cells? 40% will be cells. 60% will be plasma. 60% will be plasma. If I ask you what is serum? What is serum? Plasma minus clotting factor. Plasma minus clotting factor is the serum. How many types of cells do we have? Three. What are the name of these? RBC, WBC, platelets. These are the three cells. Okay. Apart from that, in the plasma, you will be having solid and liquid. 92% will be water, and 8% will be solid. Now, this solid can be inorganic solid, this solid can be organic solid. So what we are discussing? We are discussing total body water, how much is that? And in that water, we are having this particular water we are having in which compartment. So now we are discussing about the major thing that we are always concerned with, that is your body fluids. And in body fluids, we are having blood, most important one, right? So blood will be having what? 8% of solid, right? Plasma will be having 8% of solid. This solid will be including what and what? क्या क्या होगा इसके अंदर? What are the things? Plasma proteins will be there. Okay. Whatever things you are eating, whatever things are there, they will be present where? Albumin, glucose, sugar, everything will be present here in the plasma. Drugs, alcohol, smoking, cigarette, everything will be here itself, right? So you will be having waste products. And what is the gland? What is the glands? They will be secreting their substances directly into the blood. They are known as endocrine gland. So endocrine glands will be releasing what? Endocrines are ductless glands, so they will be releasing their hormones directly into the blood. And these are the hormones which are transporting throughout the body and reaching to the receptor. They will be reaching to the receptor, and then they will be doing certain functions. So they will be hormones. Apart from hormones, you will be having what? Plasma proteins. Okay. So let me discuss very fastly. If there is decreased levels of RBC, what do we call it? Decreased levels of RBC, erythrocytopenia. What is the disease that can happen? Anemia. How you will treat anemia? What is the classification we are using for anemia? Name of the classification: microcytic, macrocytic. Winterop's classification. Very good. Okay. So what we are going to do whenever there is decrease in the hemoglobin, we are going to do CBC. After CBC, we will be identifying how much is the hemoglobin. If the level of hemoglobin is like 5, we need to make it 7. We need to make it 7. How we can make it 7? With the help of how many units of blood? 2 units of PRBC. Remember, 1 unit of PRBC is going to increase hemoglobin percentage by 1 gram percent. Okay. So if hemoglobin is 5, I am giving 1 unit. What will it become? It will become answer. It will become 6, not 3. Okay. It will become 6. Then I will add one more unit of PRBC, that is going to make it 7. And now what I can do after 7, we do not need to do the blood transfusion. Now what I can do, I can shift the patient into oral or IV, whatever we will be identifying what type of anemia is this. So how we will identify the type of anemia? Which classification we are using, Biche? Winterop's classification. Winterop's classification will be telling whether we will be looking for the MCV. The normal size of MCV will be 80 to 100. Less than 80 will be microcytic. More than 100 will be macrocytic. Microcytic, 5 causes. Sheetal, S for sideroblastic, I for T for A for anemia of chronic illness, L for lead poisoning, lead poisoning. So out of this sheetal, which one is the most common one that you will be? Anemia of chronic illness will be there if the history is present. Okay. If the history is present, that is going to be anemia of chronic illness, but most common will be iron deficiency anemia. So how you are going to identify? MCV will be low. Okay. MCV will be low. You are going to think in the terms of iron deficiency anemia, because sideroblastic you have already diagnosed, right? Thalassemia, that should be diagnosed, right? Like a female area, if a female is coming to you with these symptoms, kya symptom honge? Patient will be having pallor, fatigue will be there, she is having weakness, pallor, physical signs you will be finding, right? You will be identifying for those signs, and ultimately you will be making the diagnosis. Now for the treatment part, what you will be doing for the treatment of iron deficiency anemia? Iron supplements. After 7 hemoglobin, we will be giving iron supplements. So you can use oral or IV. Which one is better? Always remember, same bioavailability, it will be equal. Those people who are not able to take it orally very well, those people will be taking it IV or IM. We will be shifting those females to IV or IM. Now, how much after 21 days, how much amount of iron hemoglobin will be increased? For increment of 1 gram of hemoglobin, till what days I need to give iron? 21 days. Okay, if you are giving continuous iron for 21 days, what is going to happen? There will be 1%, 1 gram percent increase in the hemoglobin. Okay, just let me know one thing. If we are discussing like that, is it going to be helpful, or do you want me to write notes? Like we are discussing like that, is it going to be helpful for the online people also? Because you guys are having the notes. Okay, we will be writing certain things, but I think if we will be discussing like a story, it will be very beneficial. You are able to remember more things. Okay, so we can go like that. Okay, all right. Speed is fine, no issues with the speed. If there is issue, do let me know. Okay, so this is how we are going to identify the iron deficiency anemia. Okay, tell me, what is the site of absorption of iron? देखो, जिनको आता है वो याद कर, रिवाइज कर लो. Those who don't know, speak with them. Okay, just repeat with them. So site of absorption of iron will be duodenum. Duodenum में the site of absorption of iron will be there. And how it is going to get absorbed? Dietary iron will be in which form? Dietary will be Fe3 plus. Remember what I've told you? 3 will be ferric. Ferric. C will be there. Okay. If C will be there, that means it is Fe3 plus. Okay. Now this needs to get converted into Fe2 plus. Fe2 plus may convert on. It needs to get converted into Fe2 plus. Now this Fe2 plus can enter with cells. It can enter into duodenal cells with the help of divalent metal transport. This was your exam question. Divalent metal transport. This was your exam question. FMG repeat question. Okay. So first of all, this Fe2 to Fe3 conversion is because of what? Yes. It is converted with the help of not intrinsic factor. Not HCl. Duodenal cytochrome B. Very, very important. This was also a question. Duodenal cytochrome B. Duodenal cytochrome. Duodenal cytochrome B is the enzyme which is going to convert this Fe3 plus into Fe2 plus. Then only this Fe2 plus can enter into the duodenum with the help of divalent metal transport. And now this Fe2 plus will be stored in the form of storage form of iron. Everyone, storage form of iron is ferritin. Apart from that, extra iron that you are eating, it this is a this is what? Think like that. This is a epithelial cell. Okay. Now what is going to happen? The extra iron will be going out with the help of ferroportin. Extra iron will be going out with the help of ferroportin. This is going to be Fe2 plus. Fe2 plus, can it travel into blood normally? Sir, Fe2 plus is not usable. It cannot travel normally. What we need to do, we need to convert this Fe2 plus into Fe3 plus. Guys, iron metabolism, definite question you will be getting. Very, very important thing. Okay. So this Fe2 plus will be getting converted into Fe3 plus with the help of one more thing that is known as hephaestine. Hephaestine. You should be remembering these names. Hephaestine is the thing, right? Now what is going to happen? This Fe3 plus. Now Fe3 plus can travel into the body. Guys, this is your lumen of GIT. Here you will be having what? Food. Whatever food you are eating, it will be here. This is your duodenal cell, epithelial cell, and this is what? Blood vessel. This is what? Blood vessel. Okay. So now what has happened? This Fe2 plus has converted into Fe3 plus with the help of hephaestine, and this Fe3 plus is going to bind with what now? Transferrin. Transferrin is formed in liver. Ceruloplasmin, transferrin are formed in liver. So transferrin will come and transferrin will act as a transporter. It is a transporter of Fe3 plus. You can remember like that. And transferrin will take it to the where? Transferrin will take it back to the liver, and लिवर में क्या कराएगा? सर लिवर में जो कराएगा करा देगा, बट वी हैव नीडेड दिस इन द bone marrow as well for the production of RBCs. Erythropoiesis requires what? Hemoglobin requires what? It requires iron, and that is why we are eating iron, right? So this one will be going to the bone marrow. In bone marrow, it will be making what? It will be making erythropoiesis. It will be making what? Iron will be corrected, right? And in the liver, it is going to the getting stored. And now what is going to happen? This liver is going to give the break. What is the break we are having? Hepcidin. Hepcidin is the break, and this is the break for ferroportin. So what hepcidin will be telling? It will be blocking the ferroportin whenever we are having enough amount of iron in the blood. But there is a disease you will be studying in medicine that is known as hemochromatosis. Hemochromatosis. What is the problem? Sir, this brake is failed. This absidine is not working. If this brake is fail, can you appreciate this iron will be coming out? It will be converting into Fe3 plus. It will be transferring in the body with the help of transferrin, and it will be getting deposited in different organs, right? If it is depositing in the bone marrow, it is depositing in the liver. What will happen to the liver? Iron deposition. Very good. That would lead to cirrhosis. Okay, it will go to the pancreas. It will cause bronze diabetes, right? It will be going to and storing to the different parts of the body. So this is what is going to happen whenever lots of iron will be coming and getting deposited whenever there is brake failure. Very important. You can expect a question from here. This is hepcidin, this is hepastine, this is the duodenal cytochrome B and DMT. They have already asked about these two questions. Okay, so there is a high chances they can ask you question from here, right? Next question they have asked is about the absorption of iron. This iron absorption is increased by what? It is increased by acid and citrus fruit. So iron should be taken along with the juice. It should be taken along with the orange juice. It should be taken along with the acidic things, right? It should not be taken with the milk, with the phytates, with the green tea, oxalates. These things are contraindicated along with the iron because it will be getting hindered. They will make some compounds which are non-absorbable. You understand this? Is that okay? Okay. So this is the first thing. First thing we are done with this. RBCs, we are done. Second type of anemia we are having is megaloblastic anemia. Treatment you will be giving what? Treatment depends. Megaloblastic or macrocytic is of two types, majorly folic acid and B12. Folic acid and B12, how you will differentiate with the levels of methyl malonyl coenzyme. What is the name of that thing? Methyl malonyl coenzyme, right? This is going to differentiate between these two, or you can directly check the levels of vitamin B12 or folic, right? Now, what you will be doing, you will be giving vitamin B12. You should be giving vitamin B12 daily. The reason being, it is a what type of vitamin? Water soluble vitamin. So it needs to be given daily, right? Vitamin D you can give weekly because it can store in the liver. It is a fat soluble vitamin. Fat soluble, what you need to remember, they can be stored in the liver. In liver, which place? Answer. Yes, answer, dear. Bolo. In liver, vitamin A will be stored. Ito cells, or stellate cells. Very good. That is going to be stored in the ito cells. Yes, correct. Very good. Okay, so they will be getting stored. Vitamin D can also get stored. Let me make a clinical integration like you are doing in the treatment of acne or in the treatment of pustular psoriasis. What is the drug of choice? Exam is near, guys. Tell me. Drug of choice for pustular psoriasis. Acetretin, very good, which is a vitamin A analog. It can remain teratogenic for how much time? 3 years. Why? Because it is a fat soluble vitamin derivative. It can get stored in the liver and it will be living in the liver for such a long time. So it can cause what? Teratogenic effect. Remember, so vitamin A, D, E, K, they can be stored. These are your fat soluble vitamins. Okay. Now, 3 years. 3 years. Acetretin is for 3 years. Isotretinoin, if we are giving, isotretinoin, if we are giving isotretinoin. Isotretinoin will be like 2 to 3 months would be fine, right? But we are keeping a distance of like 1 year. We will ask the patient. We will do the counseling before starting these drugs. When we are giving like isotretinoin, nodulocystic acne or grade 4 acne. Grade 1, grade 2, we are giving like adapalene or tretinoin group of drugs, right? But this no, this particular isotretinoin, what is the major side effect of this particular drug? Dryness. It will be killing that particular sebum is. I don't want to teach my dermatology, but the thing is, the sebum is coming. It will be drying up that sebum, right? Sebum is coming. जो gland होती है, what is the gland we are having? Sebaceous gland. Sebaceous gland will be releasing what? Sebum. Sebaceous gland will be releasing what? Sebum. Now what is happening? If there is blockage, we call it what? Comedones formation will be there, right? Comedone formation will be there. If it is blocked means what head? Black head or white head? Blocked means white head. Open means black head. These are the comedones. उसके बाद क्या होगा? Sir, there will be some accumulation of sebum. If there is some accumulation of sebum, what will happen? Bacteria will come. Which bacteria? Most common. All of them are questions. Propionibacterium, acne, not Staph aureus, Propionibacterium, acne. Staph aureus can also cause, but the most common is Propionibacterium acne. This was the question. What will happen? This bacteria will grow. You will be having what? Formation of pus. Bacteria. Characteristic thing will be pus formation. Now, what is going to happen? You are giving isotretinoin or vitamin A derivative. You know, it will be producing dryness. Sebum will be dry, bacteria will be dead. You understand how it is working? Sebum will be dry, bacteria will be dead. Most common side effect will be dryness will be there, right? This is how these bacteria are being killed, and this is how we are treating the situation, right? uh, Treatment you will be studying in dermatology. Let's come back to physiology. Okay, so what we are discussing about, second thing, now we are going to discuss RBC. We are done. Vitamin B12 supplement you will be giving. You can give by any route. It will be having same absorption. Reason being, it is a water soluble vitamin. Even if you are giving intramuscular injection, you can use it alternate days. Okay, because intramuscular has a little bit better absorption. We are adding it with the mixing it with the oils, right? Apart from that, we are giving oral. We can use sublingual, multiple drugs we are having. Second thing we are going to discuss is about the WBCs. Second thing we have to discuss is about the WBCs. Okay, last May you are having some space where you can write if you want to write. Okay, most of you, or you can use extra pages. Okay, is that okay? No issues with this? So WBCs, how many types of WBCs do we have? Granulocytes will be there. Agranulocytes will be there. Granulocytes will be having what? Sir, granules will be present. Agranulocyte means there will be no granules will be present. Okay, is it visible? Okay. Granulocytes will be having what? Granules. So what are these granules? Sir, if there are granules, they should be filled. They should be filled. What are the fill wale granules? What are the granules which are filled? Eosinophil, basophil, neutrophil, right? And these are agranulocyte. What are the agranulocyte? Try to speak. Monocytes. We are having like monocytes. We are also having what, which is lymphocytes. Okay, what they are indicating, that is important. Look here. This eosinophil is indicative of which type of parasitic and allergic infection. So if you are having allergic infection or a parasitic infection, parasitic means what? It can be, you will be studying in parasitology, there will be multiple infection, right? You will be having what? In these cases, you will be having massive eosinophilia. This eosinophilia you will also find in certain other cases like bronchial asthma. Bronchial asthma will also have what? Eosinophilia, right? Basophil is concerned with what? Histamine. Basophil is concerned with histamine, serotonin release. Neutrophil will be telling us about acute infection or bacterial infection. Acute or bacterial infection, right? This lymphocyte will be telling us about viral etiology, and monocytes are the macrophages. Monocytes of lungs. I'm asking about lungs, right? Monocytes of liver, Kupffer cell, monocytes of bone, faster, osteoclast, monocytes of skin, Langerhans, not Langerhans, Langerhans cells. Langerhans present in stratum spinosum. Okay, Langerhans cells. Apart from that, monocytes of brain. Everyone, microglial. Those who don't know, try to speak microglial cells. Okay, macrocyte of kidney, mesangial cell, mesangial cell. Okay, we have discussed about mesangial cell. Macrophages of spleen, littoral cell, macrophages of placenta of our cells. You know about this. Okay, so these are the monocytes. They are present at different places, coming from the plasma cells and doing what? doing the function of phagocytosis. Okay, whenever you are having a viral infection, viral etiology, what is going to shoot? What is going to shoot? There will be lymphocytes levels will be increased. So this is pretty much about the WBCs, right? थोड़ा थोड़ा देख रहे हैं, ठीक है? Apart from WBCs, we are having third thing. What is that? Platelets. WBC. If the level of WBC is low, what do we call it? Leukopenia. 20,000 level of WBC. What do we suspect? Sepsis. Very good. We will be suspecting sepsis. If the value is crossing 50,000, that can be a case of leukemia. Less than 4 to 11,000 is the normal value. Less than 4,000 would be leukopenia. That means person is more susceptible to infection, right? Less than 4,000, the person is more susceptible to infection. If the values are more than 11,000, that is leukocytosis. If the value is around 20,000, that means patient is going on sepsis. And if the value is around 50,000, that means this particular person is maybe having leukemia. You can go for the further diagnosis. Okay. Next thing we are going to discuss about is the platelet part. So what are the things that you should be knowing about platelets? We are having total platelet count will be 1.5 to 4.5 lakh, 1.5 to 4.5 lakh. If the levels of platelets will be low, what do we call it? Thrombocytopenia. Thrombocytopenia. If the levels of platelets is more, what do we call it? Thrombocytosis. If there is thrombocytopenia and the bleeding is happening, what kind of hemostasis disorder is this? Okay, listen to me. If there is bleeding is happening in a person and there is a low count of thrombocyte, what kind of disorder is this? Primary hemostasis, secondary hemostasis, or some? uh, Yes, what happened to you? Try to answer. I am talking about thrombocytes. Thrombocytes are also known as, guys, what you're doing. Thrombocytes are also known as platelets. Thrombocytes are also known as platelets. Okay. We are having two types of hemostasis. I've told you. First hemostasis is primary hemostasis. That means, okay, let me give you the story. Listen to my story first. Whenever you are having a cut, what is going to happen? Support me in my story. Try to answer. Whenever you are having a cut, what is going to happen? There will be bleeding. There will be bleeding. How this bleeding is stopped, sir? It is stopped in two phases. First is your primary hemostasis. Second is secondary hemostasis. Primary hemostasis, if you want to understand simply, you will be having bleeding. Normal bleeding time will be 2 to 9 minutes. 2 to 9 minutes will be the normal bleeding time. Patient will be having bleeding. Then what you are going to do? You are going to stop the bleeding. Automatically, the bleeding will be stopped normally within 10 minutes. This is known as primary or secondary? Primary hemostasis. After some time, some naughty people, what they try to do, they will try to press it. They will try to press it. Is there any bleeding? Bleeding will be happening. Yes, if you try to press it within 15 minutes, what will happen? There will be bleeding again, right? But after like 10 hours, what is going to happen? You are going to press it. Is it going to bleed? No. Now secondary hemostasis has occurred, right? So we are having primary. Hemo means blood, stasis means stoppage of blood, right? So we are having primary hemostasis, we are having secondary hemostasis. In primary hemostasis, what you are going to do? You are having four steps. What are these four steps? First of all, those things will be coming out. There will be rupture, von Willebrand factor. Let me tell you the disease itself. You can check it out in your notes. Okay. So first disease will be von Willebrand disease. Von Willebrand disease, the treatment will be von Willebrand factor. Second disease, if there is deficiency of this particular thing. Okay, let me give you. So these are the platelets. Whenever there is a rupture, what is going to happen? Those of you who are looking at first time, look here. There will be any rupture. What is going to happen? After the rupture, there will be release of certain things. Thromboxane A2, endothelin will be going out. After that, there will be release of a glue. What is the name of that glue? Von Willebrand factor. The name of the glue will be von Willebrand factor. This glue is coming like that. Now what is going to happen? Because of thromboxane A2, there will be vasoconstriction. All the platelets will be coming here, right? Now this platelets will be having exteriorization. That means something will be coming out. What is the name of this thing? GP1B, glycoprotein 1B. This is a platelet. This is glycoprotein 1B. Now this glycoprotein 1B will come and bind to the this von Willebrand factor. This von Willebrand factor is the glue. Now these platelets are coming and binding to this von Willebrand factor. Now what is going to happen? Third step. What I've told you, third step will be Degranulation. Very good. It will be degranulating. Four things will be coming out. First thing will be thromboxane A2. Second will be ADP. Third will be calcium ATPase. And fourth will be GP2B3A. And they will be making better bonds. They will be making better bonds, and this is known as primary hemostasis. Now what is happening? Primary hemostasis, the only thing which is concerned is what? Platelets. Sir, platelet is coming, they are having exteriorization, they are coming, binding to the von Willebrand factor, degranulating, binding together. This is known as primary hemostasis. Secondary hemostasis, what is going to happen? Your clotting cascade will starts to work, everything will be working. The ultimate function, I have given you the mnemonic, but the ultimate function of the clotting cascade is to make what? Fibrin, factor number 1. 12, 13, 9, 10. How you can remember? 7 will be this side. Okay. After 7, 1, 1 to ja, 2, 2, 2, 5 ja, 10. How you can remember? So here you will be having factor number 7, 1, 1 to ja, 2, 2, 5 ja, 10. This is going to be your common pathway. Whatever is left, 8, 9, 11, 12. This is going to be which pathway? Intrinsic pathway. This is extrinsic pathway. This is your common pathway. Now what is going to happen? The ultimate purpose of this pathways is what? To make factor number 1. This is a type of positive feedback. All these things I am telling you is the important information. These are all questions. Positive feedback, one of the example is clotting cascade to make factor number 1. Now what is happening? So suppose this is your this is your platelets. They are binded with the help of GP1B. They are binded with the help of GP1B, and they are having degranulation, and because of that they are having primary hemostasis. Look here everyone. Now in secondary hemostasis means what is going to happen? Sir, this pathway will be working and they will be coming and making a special layer around it. This is secondary hemostasis. Now if you try to press it, it is not going to bleed. But at this particular stage, if you try to press it, what is going to happen? It is going to bleed. This is primary hemostasis. And now whenever there is fibrin deposition, it has become secondary hemostasis. You understand? Okay. What are the four things that are coming out that you can correlate very well with the pharmacology? First thing is thromboxane A2. What we are giving thromboxane A2 inhibitors, anti-aggregant drugs, aspirin, that is going to inhibit this particular step. Second thing coming out is ADP. What you are going to block over here? Name of the drug? ADP inhibitor. Louder. Very good. Clopidogrel, that is ADP inhibitor. Third thing that is coming out is calcium. And the fourth thing coming out is GP2B3A. That is going to be inhibited by which drug? Abciximab, which is the most powerful antiplatelet drug. Done with this. Okay. Secondary hemostasis, you are going to use heparin over here. You can remember mnemonic. Heparin is going to work on the intrinsic pathway, whereas warfarin is going to work on the extrinsic pathway. Warfarin, extrinsic, PTINR will be changed. Heparin will be working on intrinsic pathway. APTT will be changed. Okay, this is what we have already done with this, right? समझ में आ गया? You know the what is anticoagulant, what is fibrinolytic, what is thrombolytic. All these differences are clear. What is antiplatelet? Is that okay? So this is about the first thing. If there is decrease in the levels of platelet, which disease will occur, bache? Thrombocytopenia is seen in very common disease. Let me give you the example. This is your dengue. Dengue, what are the symptoms you will be finding? Nowadays, you guys are having dengue. Okay, exam is so near, you have to take care of yourself. First, most important thing is to take care of yourself. Don't get ill. Don't eat outside. Don't get intestinal infection. Don't get these parasitic infection. Okay, take care of yourself. Take care of yourself, and then take care of your food. Take care of your sleep. These are the three most important things that you should be taking care for the next consecutive 75 days that you are having in your hand, right? So this is what is important. What happens in the dengue? If someone is having dengue, trust me, 10 days will be gone. You will be having 65 days for examination. So make sure you will use those mosquito repellents and take care of yourself, right? So come back to the topic. We are having dengue. Dengue patient will be having what? Patient will be having fever. Patient will be having joint pain. Okay, the clinical manifestation for first 4 days there will be fever. The manifestation that you will be getting is what? Thrombocytopenia. And because of this thrombocytopenia or platelet count will be low. What will happen to the bleeding time? Increase. Simple understanding, sir. Platelet is low. What is going to come and bind to the von Willebrand factor? Nothing, sir. If nothing is going to come and bind, is there going to be any primary hemostasis? No, you understand this. Okay. If there is von Willebrand disease, what will happen? Sir, there is no glue. If there is no glue, where this platelet is going to bind? Nowhere. You will be having what? Bleeding again. Okay. You will be having GP1B deficiency. Name of the syndrome. GP1B. B for Bernard Solier syndrome, right? What will happen? There will be no GP1B where this platelet will come and bind. There will be again bleeding time will be increased. You understand? Glanzmann's thrombocythemia, immune thrombocytopenic purpura. There will be antibody against this GP2B 3 है. अरे हवा में बात कर रहा हूँ पल्ले पड़ रही है या लिख के बात करूँ सही बताओ the ultimate purpose you should be remembering, right? This is a revision class. That is, I just want to cover more detail. That is why I'm going a little bit faster. If you are able to understand, just do let me know. अगर थोड़ा slow करना है मैं लिख के पढ़ा सकता है ठीक है What do you want? Is it fine? You understand? Are you guys understanding? Online people? Okay. So what is going to happen? Listen to me. Perfect. Okay. थोड़ा लिख के बढ़ा दो ठीक है Okay, so what is going to happen? There will be platelet, there will be decrease. We will be doing this type of hawa wala rapid revision just before examination, but at this point of time maybe I can write. Okay, so we are having this platelet count कम हो गया. If the levels of platelet is low, that means there will be thrombocytopenia. What is the normal platelet counts are less than 1.5 lakhs is the no, that is known as thrombocytopenia. What is the requirement? At which point you will be giving the platelet transfusion? Less than 30,000. Less than 30,000, you will be giving platelet transfusion. What type of platelets you are having? Two types of platelets you are having. Random donor platelet and single donor platelet. Okay. Random donor platelet and single donor platelet we are having. Okay. Two types of platelets we are having. Random donor platelet and single donor platelet. Random donor will increase the platelet count by 1 unit of random donor platelet. If I am giving to someone, what will happen? It will increase the platelet count by what is random donor platelet? You are going for blood transfusion. You are giving the blood. Platelets do not have any antigen. They do not have any blood group. So what they will do? They will put all the platelet in a big container. They will mix all the platelet. They will fill a bag. They will sell it out. This is known as random donor platelet. You understand this? This will increase the platelet count by 10,000. Whereas if I talk about single donor platelet, the person will be coming. Okay, the person will be coming and he will be donating the blood and this platelet will be segregated, right? This platelet will be segregated. This is known as single donor platelet. It will be increasing platelet count by how much, which is 30,000. So now what will happen? Now what will happen? This person will be having platelet count of 60,000 if I am giving 1 unit of platelet over here. This is how we are writing the unit. You understand this? Okay. So dengue patient, if they are coming to you, they are having high tendency of bleeding. Most likely that bleeding will be happening. The complications will be happening within 4 to 6 days. If you are having dengue, let me give you the timeline. The timeline is first 4 days will be febrile days. Hyper pyrexia will be there. High temperature will be there. You need to take paracetamol. Fifth day onward, what will happen? There will be resolving of the symptoms. You will be having 5, 6, 7 days. These are the most crucial days. Even if you are brushing your teeth, you can have bleeding. You can have vaginal bleeding. You can have bleeding from your cannula. You should be taking care of it, right? You can have, you are having low volume. That means you can have vertigo. You can fall down somewhere if you are driving a bike, right? You can fall down, you can have internal bleeding, right? You have to be very, very careful if the platelet count is less than 30,000. Second thing, after this, what will happen? Platelet count will definitely be increasing after 6 days. Okay, after 6 to 7 days, platelet count will start to rise, and your disease will be starting to decrease. Now, what is going to happen? You will be having immune reactions. Because of that, you will be having what? Rashes on the body, itching on the body. Those people who are having, they know, right? They will be having rashes and itching. You will be taking simple antihistaminics, H1 blocker, and everything will be fine, right? Within 8 to 10 days, everything will be normalized. Within 10 days, your platelet count will be restored. You understand the timeline of the dengue? What are the tests you are doing? You are doing, first of all, NS1 antigen you will be doing. Okay, then you can do IgM antibody and then you can do IgG antibody. You understand this? Okay, this is going to be the profile, right? Now we will be discussing about the plasma proteins. Platelet done, normal count, basic things we are done. Now we will be discussing the most important thing from this particular segment is plasma proteins. Plasma proteins की बात करते हैं, चलो आ जाओ. So we are having plasma proteins. What are the plasma proteins? Do you know? First one, sir, albumin. चलो albumin की कहानी पढ़ते हैं. What albumin is trying to do? Albumin, whenever it is present in the blood vessel, understand this concept. Till the time this albumin is present in the blood vessel, it will make the blood thick. Listen to me carefully. Till the time it is present in the blood vessel, it will make the blood thick. As soon as this albumin is going out from the blood, what will happen? The blood will be thin. And remember, two more concepts I am giving you. Keep this throughout your life. One is whenever a vessel is dilated, it will be releasing something. There will be some secretions. Okay. And second thing, whenever there is decrease in the albumin, what will happen? The blood will be thin. If the blood will be thin, what will happen? This blood will leak out from the vessel. This blood will leak out from the vessel and it will get accumulated. It will accumulated in the interstitial space. Okay, simple understanding. Low albumin accumulating in the abdominal cavity. What will happen? Ascites, a symptom of liver disease. Liver is making albumin, right? Liver is making albumin, patient is having cirrhosis. What will happen to the patient? No production of albumin. What will happen if there is decrease in the albumin? What is going to happen? There will be blood will be thin. If it is getting accumulated in your abdominal cavity, you call it what? Ascites. If it is accumulating in your pleural cavity, you call it pleural pleural effusion. If it is accumulating in your pulmonary things, right? What will happen? That is known as pulmonary edema. First thing you will be checking for a accumulation of fluid is below the eyes. Below the eyes, or you can have pedal edema as well, right? This particular thing can also happen in another scenario. What is another scenario? Sir, either there is no production of albumin. No production of albumin means there will be liver etiology. Second problem, sir, there is production is there, but this protein is going out. What is that particular syndrome? Proteinuria seen in the cases of nephrotic and nephritic syndrome. What will happen? Sir, albumin will be going out of the body. If albumin will be going out of the body, what will happen? Sir, blood will be thin. It will be coming and getting accumulated in the body tissues. That is what is known as what? Ascites. Ascites. You understand? Nephrotic syndrome, kidney disease, or maybe this particular etiology, what will happen? There will be ascites. If I talk in the terms of terminology, what is this albumin is going to do? This albumin is going to do, it is going to maintain your blood colloidal oncotic pressure. It is going to maintain BCOP. Simple understanding, sir, it is going to make the blood thick. It is going to make the blood thick. You understand this? Okay. All right. Next thing, after albumin, second plasma protein that we are having is what? Globulin. Second plasma protein that we are having is globulin. So how many types of globulin we are having? Three types, alpha, beta, and gamma globulin. Alpha, beta are formed in the liver, not so important for us, but the gamma globulins are important. Look here, everyone, name me. What are the gamma globulins that you know? Yes, what are the gamma globulins that you know? IgG, A, M, E, D. IgG will be telling us about what kind of infection, Vijay? Chronic infection. Chronic infection. IgM will be telling us about acute infection. IgA will be a secretory antibody. It will be secreting throughout your secretions. Okay. You must have seen the dogs. They are always licking their wound, right? Any animal, they will be having, it will be present in secretion. It will be coming in the saliva, right? IgE is responsible for the, you know what is IgE mediated disease? IgE mediated disease, allergy, bronchial asthma. IgE antibody and histamine complex will be there, mast cell complex basically. And what will happen? There will be rupture of mast cell and there will be histamine that would be leading to bronchoconstriction. So this is responsible for the allergic response. Very good. Okay. And D will be working as a complement system on the alternate pathway, right? So this is what is going to be remembered, right? What about albumin, globulin? We are also having what? Fibrinogen. Remember this fibrinogen. Now I think you are in a better state to understand this. Fibrinogen is what? factor 1A, not A, it is factor number 1. And this is the fibrinogen which is going to convert into 1A. And this one is what? Fibrin. So two things I have told you. One is platelet, another one is fibrin. Both of them are having function of clotting, but different places. This fibrin is responsible for primary or secondary hemostasis. Fibrin is responsible for secondary hemostasis. Clotting cascade complete responsible for secondary hemostasis. Okay. Clotting cascade में issue होगा. If APTT will be increased, you can easily identify hemophilia A, B, C. एक बार notes देखना. Once go through notes, you will be able to understand, right? So that is going to be your fibrinogen. That is going to be your fibrinogen. That is going to be your platelet. Is that okay? Now, tell me. Let me ask you a question. If a patient is coming to you with some kind of a disease and he is having what is this type of infection? This is a chronic bacterial infection. Chronic bacterial infection. But generally, bacterial infections are not so chronic. This can be a pseudomonas infection, but generally, bacterial infections are acute infection. Fungal infections are chronic infections. Okay, fungal infections can be chronic, right? So, for example, try to answer this one. Lymphocytosis. This is going to be acute viral etiology. This is how you are going to identify about the infection. This is how you are going to identify about the infection. If there is a person who is having serious kind of discharge from the nose, what you will suspect? Serious kind of discharge. नाक से पानी आ रहा है सर आंख से पानी आ रहा है water is coming from nose and mouth. It can be a viral infection. What you would like to give? Anyone who is giving me right answer. Symptomatic treatment. What you would like to give in symptomatic treatment? Anyone raise your hand. Symptomatic is not water. Yes? Someone is saying antihistaminics. Very good. That can be given. Listen to me. Listen to me. Let me give you the explanation. Suno. ध्यान से सुनो. What is happening? Sir, vessels are dilated, and because of that, mucus and water is coming from the nose. Nose or eyes, whatever vessels are dilated, you can give what? You are using histamine blocker, that is cetirizine. You can use cetirizine. Cetirizine is what? H1 blocker. Tell me the function of histamine. And also, second question. I'm asking only questions. Histamine is the precursor that is coming from which amino acid? Very good. It is coming from histidine. Okay. And what is the function of histamine? कौन करा रहा है bronchodilation? Broncho constriction. Apart from that, vasodilation. Simple understanding. Whenever we are having vessels dilated, RBCs will be coming out. That is why it is giving us red appearance. It is a local inflammatory thing. It is a part of which system? Which type of glands? It is a part of which type of glands? We are having autocrine, endocrine, exocrine glands. It is a part of autocrine. Autocrine glands are those glands which are exerting a local effect. मच्छर काट गया क्या होगा? If because of mosquito bite, there will be some local effects. There will be release of histamine. What will happen? Vessels will get dilated. Vessels will get dilated because of what? This histamine. Histamine has vasodilation, bronchoconstriction function. You are doing what? You are giving H1 blocker, cetirizine. What it is going to do? It is going to block this vasodilation. You will be having what? Symptomatic treatment. नोज के अंदर क्या हो गया? ब्लॉक हो गया. What are the drugs you are taking? Alpha 1 agonist, phenylephrine, Otrivin nasal spray. All these things are going to cause what? Alpha 1 function is vasoconstriction. Okay. Okay, done. So this is how you are going to treat this thing, right? Okay, let's move to the next topic. इस पे रह जाएंगे. The next topic we are having total body water. How you are going to identify the total body water? Look here. How you are going to identify the total body water? Total body water, to identify, we are having isotopes. First of all, we are having different isotopes. You can use H2O. You can use, if you want to calculate water, you can use something like H2O, right? What is the something like H2O? That is going to be your deuterium and tritium. These are the isotopes. These are the isotopes. Okay. ECF, how you will identify ECF? Okay, just remember whatever I'm marking, just remember that. We are having inulin, we are having sodium, that is also a radioisotope of sodium. Intracellular fluid, if I want to know what is intracellular fluid, what I can do? I can do total body water minus extracellular fluid. That is going to be your intracellular fluid. What about plasma volume? Two things are important. Iodine, iodinated, albumin, and second thing is your Evans blue dye. That this is you have to remember. Blood, if you want to identify blood, you need to give chromium labeled RBCs. Interstitial fluid, ECF में से क्या minus कर दोगे? From ECF, okay, from ECF we will be minusing blood plasma volume. Blood plasma volume. For ionic composition, we are having different things. Look here. They will be asking you questions. Simple question. They will be asking you, what is the most abundant extracellular cation or anion? First of all, let me give you understanding. Cation means it will be having T, and T is looking like a positive thing, right? Is it a positive thing? So cation is a positive charge. This one is extracellular compartment. This one is intracellular compartment. So if I ask you cation, you will be telling me about the positive charge. If I ask you about anion, you will be telling me about the negative charge. So my question, most abundant extracellular cation. You understand what is I'm talking about? Extracellular means bahar zyada kya hoga? What will be more outside? That is going to be your sodium. Most abundant intracellular cation, potassium. Most abundant intracellular cation will be potassium. Intracellular I am talking about, and cation means positive charge. If I talk to you, if I ask you most abundant intracellular anion, phosphate and inorganic proteins. These phosphates and inorganic proteins, listen to me carefully, they are producing a effect. They are producing a effect which is known as Gibbs-Doman effect. Gibbs-Doman effect. They are the they are the proteins. They are going to produce what? A effect that is going to be Gibbs-Doman effect. Reason kya hai? What is the reason? Sir, they are non-diffusible through the membrane. They cannot diffuse just like your sodium, potassium, right? So they are non-diffusible. That means they will be staying inside, and because of that, what is going to happen? There will be some changes in the resting membrane potential, right? Simple understanding. Let me give you simple understanding. If the question is coming and question is talking about phosphate, non-diffusible ions, diffusible ions, sodium, potassium are going coming, and phosphate and proteins are staying. You have to remember that the person is talking about the effect. This is known as Gibbs-Doman effect. Is that okay? Okay, क्या बोलेंगे? That effect is known as Gibbs-Doman effect. Okay, so this type of question they are asking. Till now, what they have asked, they are giving you certain values. They will be giving you values like potassium is 10, chloride is this much, and this potassium is this much, sodium is this much. And then they will be asking you, they will be giving you the values. Okay, so if they are giving you maximum values of sodium, that means which compartment they are talking about? Extracellular compartment. If they are giving you maximum potassium, that means which compartment they are talking about? Intracellular compartment. Are you able to do this type of question? They should not be get wrong, right? Now, we will be discussing about the basic structural and functional unit of life. That is what? Cell. Cell will be having what, which? Mitochondria. The function of mitochondria will be आगे बढ़ो थोड़ा, पावर हाउस से आगे बढ़ो. Okay. Beta oxidation of what? Fatty acids, Krebs cycle, ETC, TCA cycle, वही एक ही बात है, ETC, TCA cycle, apoptosis, okay, oxidative phosphorylation, same things will be going on. Ultimate function, let me write it for you. Look here. So we are having ATP synthesis. First thing, ATP synthesis. ATP is what? Adenosine triphosphate. Three phosphate molecules are binding together, and they will be having bonds in between. Whenever this bond is broken, there will be release of energy, right? Second one, we are having beta oxidation of fatty acids. Important function. Okay, we are having what? Beta oxidation of fatty acids. TCA cycle will be there. TCA cycle or electron transport chain will be there. The process of apoptosis is also happening here, right? These are the important functions that you should be knowing about mitochondria. Sir, everything is going to work inside the mitochondria, right? What is the function of this peroxisomes, bache? Okay, they are having catalase enzyme, which is going to block, which is going to break. Okay, they are like single person, single people. What they are going to do? They are going to break H2O2 with the help of enzyme that is going to be catalase. It is going to make H2O plus O2. There are certain functions. Yes, first function, they are going to generate and degrade free radical, and free radicals are single person wherever they are going to come in contact with single log kya karte hain, they are going to destroy the life of others, right? That is what is it is going to do whenever it is going to come in the contact with any cell, be it your skin cell, be it your blood cells, be it your bacteria, be it your virus, any cell it is going to come in contact with, it is going to destroy it, right? Free log, single log, this is the same purpose, right? Second thing, yes, they are also responsible for the oxidation also, right? Oxidation. If there is a syndrome, question they have asked you based on the syndrome. Okay, there can be two syndrome, two diseases can happen. One is known as Zellweger syndrome, and second disease is Refsum disease. Right? These are two paroxysmal disorder that you should be remembering. What is the function of rough endoplasmic reticulum? Protein synthesis. Okay, the question they have asked, and there is a high probability abhi NEET mein pucha hai, they can ask you an FMG examination, is that okay, acetylcholine or neurotransmitter, all the neurotransmitter are getting formed by what? RER, which RER? Yes, very good, that is ribonuclear proteins. Okay, so ribonuclear proteins are present in the cell body, and they are going to make what? Neurotransmitters like acetylcholine. Acetylcholine, the acetyl is coming from where? Yes, it is coming from the glycolysis, acetyl coenzyme A. Same story. It will be going to the for the storage. This is the acetyl coenzyme A, which is going to convert into acetylcholine. Epinephrine, norepinephrine coming from where? What is the precursor? Everyone remember this, the precursor is tyrosine. Okay, the precursor is tyrosine. Very good, Simi. Right? The precursor is tyrosine. Tyrosine is going to make what? T3, T4. Biochemistry. I think you must have learned how to make thyroglobulin, T3, T4. Okay, apart from that, you are having epinephrine, norepinephrine, dopamine, and melanin. Remember, tyrosine is present in tea and coffee, right? Those people who are drinking tea and coffee, your mother will always say you will get black because it will be releasing what? Melanin. It will be concerned with melanin. Those people who are taking black coffee before gym, it will be making what? T3, T4 epinephrine. Activation of a system. Sympathetic, you will be running, you will be increasing your heart rate. Sympathetic nervous system, increase your heart rate. What are the three things that are present in your heart? SA node, AV node, muscles. SA node is getting activated. What will happen to heart rate? Increase. AV node is activated. What is the function? Conduction. Current from above chamber will be coming to the below chamber. That is known as conduction. Muscle is getting contracted. What will happen? Contraction. Muscle contraction with the special mechanism. Anyone? With the calcium special mechanism. Name of that mechanism. Anyone? Muscle contraction in cardiac muscles. जोर डालो. Yes? Yes? Calcium, calcium induced CI, CICR, calcium induced calcium release. Very, very important question. This can be asked. Okay. Basically, what is going to happen? A little amount of, listen to me. Muscle contraction कैसे होता है? Listen to me. A little amount of calcium will be coming inside a cell. It will be asking for some calcium to the sarcoplasmic reticulum. They will be giving some calcium to the this calcium. They will produce a contraction. After that, what will happen? This calcium will be again taken up by which pump? Guys, which pump? Calcium is taken up by again. That is different. That is skeletal muscle. RYR, DHPR is skeletal muscle. I'm talking about cardiac muscle. वापस कौन मांगता है उधारी? सर्किट, सरका, circuit, Sarka is going to take the remaining calcium back, right? So Sarka is the pump, sarcoplasmic endoplasmic reticulum calcium ATPase pump. Whatever यहाँ पर calcium आया, this calcium is coming, this calcium will go to sarcoplasmic reticulum and it will ask for like 100 molecules of calcium. They will give you 100 molecules of calcium. Now you are having 110 molecules of calcium. And now you will be having what? A good contraction. After contraction, this 10 molecules will be going out from here. And the 100 that they have asked will be going back to this particular pump with the help of SARCA, sarcoplasmic endoplasmic reticulum calcium ATPase pump. Do you understand this? Okay. कौन सी दवाई बंद करती है? Which drug is going to block this particular calcium exit? Okay, listen to me. When do we want to increase the contractile power of heart? I think थोड़ा होच पोच हो रहा है. When do we want to increase the contractile power of our heart? Heart failure. So heart failure, acute heart failure. Inotropes, apart from inotropes. Yes, what is the name of that drug? Digoxin. Digoxin is going to block this particular thing. And now what is going to happen? Now extra calcium will be retaining inside and the power of contraction will be increased. You understand? Right? Digoxin. Very good. Shravan, right? Okay. So this is the question they have asked you. Ribonuclear protein. It is a type of rough endoplasmic reticulum present in cell body. ये तो पता है ना cell body क्या होता है? What is cell body? You understand now? What is cell body? What is neuron? What is axon? Okay. Next one we are having centrosome. Centrosome for the cell division. Microtubules we are having like certain filaments we are having. We will be discussing about that. Lysosome. LSD पढ़ लेना. LSD from the biochemistry you have to remember, right? But lysosome the function will be. Is it going to be acid mediated thing? Yes, this is going to be acid mediated function. Acid mediated. And acid is formed in which cells? Body में acid कौन से cells में बनता है? Which cells are making the acid? Parietal cell. Wonderful. Parietal cell will be having which pump? Proton pump. Proton pump is going to make which acid? HCl. Answer me, guys. Okay. Cell membrane. Cell membrane is present in animal cell or plant cell. Oh, we are not concerned about the plant cell, but do we have cell wall? No, we do not have cell wall because you are having a class of drugs, cell wall synthesis inhibitor. Can anyone tell me some examples? Macrolides. Why you are telling me macrolides? Name of the drugs. Amoxicillin. अरे बेवफा छोड़ो इधर आ जाओ. Okay. We are having like penicillin, amoxicillin, not azithromycin, cefixime, all this cephalosporin, everything is what? Cell wall synthesis inhibitor. If we have cell wall, game is over, right? Bacteria has cell wall, we are giving cell wall synthesis inhibitor, they are cidal drugs. Those you are telling me azithromycin, it is not cidal, it is static drug. That is why we need to take it for a 3 days or a 5 days course, right? We should not stop it, right? This is going to be your cell membrane also known as plasma lemma. On the cell membrane, the question they have asked you, what is the major component of the cell membrane? Be it protein, carbohydrates, or fats. Remember, proteins is the major component of this cell membrane. Proteins are the major component of the cell membrane. 45% of the things will be protein. What are the three types of proteins we are having? And look at either the protein is integrated. This is your integral protein. Either the protein can be present with the lipid. This is your lipid anchored protein. Either the protein is providing the structural support. That is going to be your structural protein, right? So these are the different types of proteins we are having. If there is mutation of CD55 or CD59 or DAF or MRIL, what is going to happen? Wonderful. CD55, CD59 or DAF or MRIL mutation will lead to paroxysmal nocturnal hemoglobinuria. right? If there is mutation of spectrin, what will happen? Which is a structural protein? Hereditary elliptocytosis. If there is mutation of ankyrin, spherocytosis, hereditary spherocytosis. Okay. If there is mutation of dystrophin mutation हो गया. Dystrophin mutation will lead to Duchenne muscular dystrophy. Present on which chromosome? Du- One. Chromosome number one, largest gene, right? If there is partial loss of this dystrophin, what will happen? Baker's muscular dystrophy. Bolo sare, which dystrophy? Baker's muscular dystrophy. Okay. Chromatin is the condensed form of chromosome. Nucleus will be having condensed form of DNA. Smooth endoplasmic reticulum will be having three function. Question has been asked. What are the three function we are having? First one, someone please mute their mic. Okay. What are the three functions we are having? First, very good. Steroid hormone biosynthesis. Whatever steroid hormone we are having, they are formed because of this smooth endoplasmic reticulum. Second function, whatever drugs we are eating, they will be having detoxification with the help of which enzyme? Cytochrome P450 enzymes. Okay. Third thing, storage, simple understanding, sarcoplasmic reticulum. Let me make an integral connection. If there is mutation of this RYR gene, what is going to happen? How? How? Through? Okay, let me make the understanding. Look here, neurotransmitter will be coming from where? Acetylcholine. Acetylcholine will be coming, it will be activating sodium channels. Okay, sodium channels are going to activate your DHPR, dihydropyridine receptor. Someone was asking, right? This dihydropyridine receptor is going to activate your ryanodine receptor. And remember the question. The question is that NEET PG last exam question. This is a mechanical interaction. This is not a chemical, this is a mechanical interaction. The reason being the space between these two things is just 15 nanometer, right? So they will be doing a mechanical interaction, and what will happen? You will be having release of calcium from sarcoplasmic reticulum, and calcium is responsible for three function. Remember, from now onwards, just remember three function of calcium. First function, calcium in the vessel, vasoconstriction. Calcium in the muscle contraction. Calcium going into the cell, something will be coming out of the cell. That is known as exocytosis. That is known as exocytosis. So now what is going to happen? This calcium will be released, and calcium will be causing in the muscle, it will be causing vasoconstriction. In the vessel, it will be causing vasoconstriction. In the muscle, it will be causing muscle contraction. And in the cells, it will be doing what? Exocytosis. Multiple neurotransmitters will be coming out. Multiple vessels will be contracted. Multiple muscles will be contracted. You will be having hypermetabolism. And this is what is known as malignant hyperthermia. Complete body will be shivering. And this is what is known as what? Malignant hyperthermia. Drug of choice for malignant hyperthermia? IV sodium dantrolene. Okay. These Golgi apparatus, Golgi vesicles, they will be packaging up the proteins that is made in the rough endoplasmic reticulum. Okay. Okay. Now we will be discussing about the cytoskeletal filament. What are the cytoskeletal filament that we are having? First one is your kinesin. What is the function of kinesin? Forward axonal transport. Listen to me. Look here. This is your neuron. This is your axon. Okay. This is your synapse. And here you will be having what? Multiple dendrites will be there. Here you will be having what? Multiple dendrites will be there. So these dendrites will be taking up all the information. This information will be going to this cell body. And now from this cell body, what is going to happen? This is going to be to your axon. And now this axon will be releasing their neurotransmitter. ये समझ में आता है? This is your axon. This is your synapse. This is your synapse, right? Now what is going to happen? The forward axonal transport. That means all the information from the brain is going to the lower part of the body, that is known as forward axonal transport. What is reverse axonal transport? Reverse axonal means the information from the lower part will be now coming up to the upper part, right? And reverse axonal transport, you can remember Dr. DR, you can remember dynein is responsible for reverse axonal transport. Okay, dynein is responsible for the reverse axonal transport. Now, what you need to remember, look here, we are having two diseases that are important. Question has been asked. One is rabies, second one is tetanus, right? Rabies, the virus. What is the virus? Name of the virus? Lissa. Very good. Lissa virus is going to come from the, for example, you had a bite on the leg, kutta पैर में काटा, right? Now, what is going to happen after the bite? This rabies virus is going to come to where it will be traveling, it will be traveling all the way through my neck, back of the neck, and it will be going to the hippocampus. And what are these bodies known as? Negri bodies that you will be finding in the postmortem. अभी ऊपर कैसे है? How this thing is coming on the brain? Negri bodies, dog has a bite on the leg, right? How these negri bodies are traveling throughout this journey with the help of reverse axonal transport, that is your dynein. Second story, tetanus. In tetanus, what is going to happen? You are driving a bike, or you are like you are going on a bike and you had an accident. You had a gravel rash. Gravel rash, matlab you will be studying in FMT. You had a rash, you had a bleeding, and now what is going to happen? What is the causative agent for tetanus? Clostridium tetani. Clostridium tetani will be making spores. Those spores will be present in the soil, in the rusted iron. They will be coming in contact with your blood. Till the time they will be coming in contact with your blood, they will be traveling, they will be getting activated, they will be going where? To the spinal cord. They will be going to the spinal cord, and now what they will be doing? They will be inhibiting the inhibitory neuron. If inhibiting the inhibitory neuron, what is going to happen? There will be constant contraction, and that is what is going to give you a specific posture known as opisthotonous posture. Okay. Second thing, it will be going to your muscle, trismus. Which muscle is included? Anatomy question. Medial pterygoid muscle. Medial pterygoid will be, yes, rhizus sardonicus. Medial pterygoid will be getting infected, and you will be having what? Lockjaw. That is why tetanus is also known as lockjaw. Now, how this thing is traveling all around the way to the spinal cord and all these things with the not negri. I'm talking about tetanus, right? I'm talking about tetanus. It is Clostridium tetani. Okay, so dynein is responsible for the reverse axonal transport. So you are having an injury. You know, both of them are 100% fatal disease. Both of them are 100% preventable disease as well, right? Both of them we are having vaccination. So we should be having that vaccination for both of them, right? You understand this? Both the diseases. Polio, yes, polio can also travel. Polio can also include your lower motor neuron also, right? Next is about the tubulin. Next is about the tubulin. What about tubulin? Tubulin is going to responsible for the cell division. It is also going to be responsible for the cell division. What are the drugs that are going to inhibit this tubulin? Vinca alkaloids. What are the examples? Vincristine, vinblastine. Vincristine, vinblastine are the vinca alkaloids that are going to cause inhibition of cell division. Okay, now let's talk about the intermediate filament. They are the static filaments. What are the examples? First one we are having is keratin. Keratin is a marker for carcinoma. And one more thing you will be finding in the liver, alcoholic liver disease. Those people who are drinking alcohol, in these patients, you will be having a special body. These are known as Mallory Dank bodies. Mallory Dank bodies seen in the cases of alcoholic liver disease. Okay. Desmin we have seen in the chapter of contraction, right? In the muscle contraction, Desmin is a marker of sarcoma. Vimentin is a marker for fibrosarcoma. Okay. GFAP, glial fibrillary acidic proteins. GFAP is a marker for glial. It is a marker for astrocytoma. And function of astrocytes will be, what is the function of astrocytes? Yes, very good. It is going to make blood-brain barrier, right? And blood-brain barrier will be having which proteins? Wonderful. That is going to be claudin and occludin. If there is mutation of lamin, which disease is going to occur? Progeria, POW movie, progeria, premature aging will be there. Lemon mutation will lead to premature aging, right? And this is your actin, which is a type of contractile protein, right? Cell membrane transport, how these things are getting transported through and through, that is what we are going to learn now. So we are having different types of mechanism. First of all, there will be no use of ATP. If there is no use of ATP, that means it is a passive transport. If there is utilization of ATP, that means it is a active transport. Okay, so in passive transport we are having two things. First one is your simple diffusion, second one is your facilitated diffusion. Simple diffusion is based on a law. What is the name of this law? Fixed law. Fixed law. It is based on a fixed law. That means the more the concentration of the substrate, the more will be the diffusion. Okay, so this is going to be a normal concentration gradient thing. Okay, what about this facilitated diffusion? Two things you have to remember. What are the two examples? One is your glut and second is your aquaporine. Remember, glut and aquaporine do not require energy. They are a type of facilitated diffusion. They are a type of facilitated diffusion. They do not require energy. Done with this, we are having like channel proteins and carrier proteins depending on the substance, right? Active transport, if I talk about active transport will require the ATP or energy. We are having like vesicles, we are having pumps, right? We are having vesicular transport, we are having pump transport. Endocytosis means what? Something is coming inside. Endocytosis का क्या मतलब है? Something is coming inside. It means something is coming inside. What is the protein that are responsible? Remember, these are your megalin and clathrine. Previous year question, megalin and clathrine, right? These are the proteins which are responsible for endocytosis. What about exocytosis? Which are the protein responsible? These are your snare proteins. Snare proteins are responsible for exocytosis. Okay, if the material that you are engulfing, it is solid. If the material that you are engulfing is solid, what do we call it? Phagocytosis. If the material is liquid, if the material is liquid, this is known as पिनोसाइटोसिस और सेल ड्रिंकिंग भी बोलते हैं इसको, ठीक है? सेल ड्रिंकिंग और पिनोसाइटोसिस. व्हाट अबाउट दिस पर्टिकुलर पंप? वी आर हैविंग लाइक प्राइमरी एक्टिव ट्रांसपोर्ट एंड secondary active transport. Primary active transport, definite question. Secondary active transport, very very important. So when you see primary and secondary active transport, look for the name. If in the name it is written co-transporter, okay, just giving you the example, exchanger, okay, Simport, co-transport, exchanger. These are the things, if you are finding, this is going to be your secondary active transport. If you are finding sodium, potassium, ATPase pump, ATPase pump, and they are giving ATP for the same utilization, then your answer will be primary active. There are not much examples. You can remember like proton pump is an example of primary active transport, and every cell will be having what? This sodium, potassium, ATPase. This is one of the most abundant pumps in the body, right? All right. So, like if I ask you some examples, sodium iodide symport. Sodium iodide symport is an example of. Sodium iodide symport is an example of secondary active transport. Sodium potassium 2 chloride. Sodium potassium 2 chloride pump. This is also example of secondary active transport. Okay, कर लोगे ये वाला question, right? Next, we are having on the list is GLUT and SGLT. GLUT is glucose transporter. SGLT is sodium glucose transporter. Okay, sodium glucose transporter. GLUT one is present. BKP, that is going to be your brain, kidney, placenta. You can remember. GLUT two is very very important. कहाँ present होगा? What is the location? Pancreatic cells. Okay, GLUT 4 will be present, heart cells, skeletal muscle, adipocytes. Okay, F45, F4 fructose. F45, F4 fructose, that is going to be your fructose absorption. SGLT1 is present in the small intestine and kidney also. Remember what I've told you. SGLT2 is definitely present in the kidney. Definitely SGLT2 is present in the kidney in the part of PCT, but SGLT1 is also present over there, right? In minute amount, but it is present. You should be remembering that, okay? Is that okay? So these are your SGLT and GLUT. SGLT are the example of primary, secondary active transport. GLUT are the example of facilitated diffusion. GLUT and aquaporin, don't make this question wrong. Don't make this question wrong, okay, bache? Look here. Now is your cell junctions. So we are having two cells binded with each other with the help of something something, right? So what are these something something? We are having tight junction. Tight junction is made up of which proteins? Occludin and claudin. Okay, they are present in your blood-brain barrier. And one more thing I have taught you, that is blood-testis barrier. Adherent junction are present because of actin and cadherins. ये पढ़ोगे cadherins you will be studying in pathology. Desmosomes we are having. Suppose this is one desmosome, sorry, this is one keratinocyte, this is another keratinocyte. These two keratinocytes are binded together with the help of desmosomes. If there is no desmosome, which disease will occur? Pemphigus. Okay, this disease is known as pemphigus. So we are having desmoglein, desmocolin, desmoplakin, or placoglobin. Desmoglein 1 is concerned with pemphigus 1. 1. 1 is first, foliaceous. 3 is vulgaris. Okay, gap junctions we are having. Name of the disease will be pemphigus, which is a intraepidermal or intradermal blistering disorder. Dermal. Keep your concepts clear. It is a intraepidermal thing. Okay, dermis का कोई लेना देना नहीं है. There will be no role of dermis either in the either either in the cases of pemphigus, either in the cases of bullous pemphigoid. दोनों में नहीं है. Okay, so this is going to be pemphigus. It is a intraepidermal disorder. Okay, intraepidermal. Look here, gap junctions, maximum gap junctions. I have told you, gap junctions are maximally present where? Cardiac cells. This is why complete cardiac cells are contracting at a single point of time. This is known as cardiac syncytium also, right? So these are your gap junctions made up of which protein? Connections. And if there is mutation of these connections, which disease will occur? CT, CMTD. CMTD is what? Charcot-Marie tooth disease. Charcot-Marie tooth disease. Okay, very good. What about hemidesmosomes? So hemidesmosomes are present where? Between cells and basement membrane. Okay, this is a cell, this is your basement membrane, this is another cell, this is basement membrane, this is one desmosome, this is another desmosome. देखो इधर, right? This is one desmosome, this is another desmosome, these are two basement membrane, these are the basement membrane, and these are two hemidesmosomal protein. Maybe this is BPHE1, maybe this is BPHE2. If there is antibody against this BPHE1 or BPHE2, what is going to happen? There is going to be some space, and in that particular space, if the fluid is getting filled, that is what is bulla, right? That is going to be a disease known as bullous pemphigoid. Bulla means lesion, clear fluid filled lesion more than 1 centimeter. Pemphigoid. Done. Okay. Do you understand this? Okay. Next is homeostasis. Homeostasis means what? Maintenance of internal body environment as compared to the external body environment. This is known as homeostasis. External environment to internal environment, right? We are having like negative feedback for this. We are having like positive feedback for this. And we are having feed forward. Negative feedback means what? It is going to give you increase in something will lead to decrease in something. That is, increase in BP is leading to decrease in BP by activation of baroreceptor, maybe. That is going to be a negative reflex. Positive, the mnemonic you have to remember is claps or clasp, whatever you can remember. C for, yes, speak with me. C for clotting. L for LH surge. A for action potential. P for parturition, and S for shock. Okay, S for shock. These are the positive feedback. Feed forward क्या होता है? What is feed forward? Sir, just thinking about the food, what is going to happen? My mouth will be having salivation. My stomach will be having gastric acid secretion. How much is the gastric acid secretion in cephalic phase? 30%, not 50, 30% of the acid secretion will be there. This is known as cephalic phase of gastric digestion. Wonderful, right? Thinking about the exercise, just thinking about going to the gym, what will happen? My heart rate will increase, my respiratory rate will increase. This is what is feed forward. That means here you will be having anticipation. Anticipation will be there. Okay, anticipation will be there. Next system on the go we are having is kidney. Kidney. How many kidneys do we have? Two. Who's saying one? एक दे दी क्या? So you have got new iPhone 16 Pro, right? Wonderful. It's worth it, guys. It's a new iPhone. It's worth it. Some people think like that. Okay, my dear students, come back to the topic. Okay, tell me how much amount of urine do you make in a day? How many minutes in a day? Look here, everyone, keep quiet. Shh, don't talk. How many minutes in a day? E का पूछ लियो है? How many minutes in a day? Some people are like what they are asking, right? They'll get to know. Look here. Oh, wonderful. Akshay is on fire. Okay, look here. So to remember this, I am going to make you understand what is GFR, how it is coming, how you are making the urine. Then only we are able to understand how it is happening. Okay. किडनी की कहानी सुना रहा हूँ, 5 मिनट ध्यान से सुन लो. सुसु कैसे बनता है, जाते रहते हो, सुनो मेरी बात को, ठीक है? 2 मिनट सुनो. Okay, in a day you will be passing out approximately around 1500 ml of urine, right? In a day there will be 1440 minutes. So that means every minute there will be 1 ml of urine will be formed. Can I say that? Right? Your cardiac output will be your heart rate into stroke volume. How many times your heart is beating in a minute? Let's say 72. What is the stroke volume? That is going to be your end diastolic minus end systolic. Now you got it how it is coming, right? So that is going to be your 70. So cardiac output, can I say approximately 5 liter of blood is getting formed, right? In a minute, listen to me in Hindi, in a minute, your heart will be releasing 5 liter of blood. Okay, in a minute, your heart will be pumping 5 liter of blood, and that 5 liter of blood, 20% will be going to the kidney. Out of that 5 liter, so 20% will be going to the kidney. So 20% will be 1 liter will be going to the kidney, right? Out of that 1 liter, what I've told you, 40% will be cells and 60% will be plasma. So 600 ml will be plasma, right? Out of this 600 ml plasma, only 20% is going to get filtered. Yes, and that is going to be 120 ml approximately, and this is your glomerular filtration rate. So you understand, your heart is pumping the blood, and that pumped blood is going to the kidney, and in the kidney, how much is getting filtered? That is what is known as glomerular filtration rate, right? Out of that glomerular filtration rate, what I have told you, only 1 ml will be formed in a day. 1 ml will be formed in a minute, right? And how much is going to the kidney? 120 ml per minute is the GFR. Out of that, only 1 ml will be urine. What happens to the 119 ml? It will be getting reabsorbed. Let's try to understand what are the different pumps that we are having and how it is getting reabsorbed. Okay, let's begin. So nephron is the first primary basic structural and functional unit of the kidney, right? चलो शुरू करते हैं. Okay, let's start from here. So first thing that we are having, you understand this? Come, let me give you the complete story first. So this is going to be your heart. Heart will be releasing your cardiac output. This is going to come via afferent arteriole. This is going to be efferent arteriole exit. And can you appreciate this first part is proximal and it is convoluted? Yes. So can I call it proximal convoluted tubule? Yes. Okay. This part is descending and limb of loop of Henle. This part is ascending limb of loop of Henle. And then this part is distal. Distal, and it is also convoluted, sir. Can I call it distal convoluted tubule? Wonderful. Now we are having what? Collecting duct, multiple collecting ducts, draining the blood into, draining the urine into. अरे ureter तो लाओ. Without ureter, how the bladder will come, right? So you will be having both the ureters coming from both the kidneys. Okay, how many urethras? Two. Urethra. Guys. Are you guys sleeping? You will be having one urethra with the two urethra. So we are having one urethra that would be going out and it will be taking what? Urine out to the urinal. You understand this? This is the complete story from the heart to the urine making and going out. These are the two ureter that you are having. These are ureter, guys. This is your urethra. Okay. Important है. Don't forget, guys. Okay, दिक्कत हो जाएगा. Come back. So we are having what? Different things. Let's try to understand this. First of all, first thing that we are having, sir, plasma proteins are not getting filtered. They are big. They are big. They are not getting filtered. What are the three important reasons? What are the three important reasons for that? First thing, size. Second thing, glomerular basement membrane is negatively charged because of what? Heparin sulfate. Okay, size of the pore will be -70. Suppose this is your glomerular basement membrane and this is your plasma protein. So first thing, sir, this is negatively charged. Proteins are always negatively charged. So is it going to pass through it? Sir, negative negative will repel each other. It is not going to pass. Second thing, sir, the size is already small. The size is already small, so it is not able to go out. Okay, and third thing, you will be having these foot processes of the podocytes which will not allow them to go out. And this foot processes of podocytes will be made up of three things. First is your nephrin, second is your podocin, third one is your alpha actinin 4. Nephrin is coded by which gene? NPHS 1. Podocin is coded by NPHS 2 and alpha actinin 4 mutation will lead to focal segmental glomerulosclerosis. Okay. Now we are having PCT. Let's try to understand what will happen in proximal convoluted tubule. In proximal convoluted tubule, the first pump that we are having is known as carbonic anhydrase pump. The first pump that we are having is known as carbonic anhydrase pump, right? Most of the things will be getting reabsorbed here, like 65% of the sodium chloride. And remember concept, the concept is sodium is like a beautiful girl. Sodium is like a beautiful girl and water are like the boys, right? She is the crush of the water, right? So what will happen? Water will definitely follow. So wherever the sodium will go, water will definitely follow. So what is happening over here? 65% of the salt is going out. If 65% of the salt is going out, 65% पूरा का पूरा जाएगा सर, कोई बेईमानी नहीं है ना. 65% of the water will be going out, right? 65% will be potassium going out, 65% will be urea. Why I'm teaching you this? Because they have asked you this question, right? 70% of the calcium has been asked, 80% of the bicarbonate has been asked, and this is the recent question they have asked you. 100% of the glucose and amino acid will be getting reabsorbed. 100% of glucose and amino acid will be getting reabsorbed. बात समझ में आ रही है? The bath is simple. The thing is simple. What is the thing that we are having? When we are having PCT, through the PCT, when urine is getting formed after GFR, urine is getting formed, sir, 65% of the salt and water will be getting reabsorbed. Which is the pump that is going to be there? This is known as carbonic anhydrase pump. This is known as carbonic anhydrase pump. And if there is carbonic anhydrase inhibitor we are giving, what is the drug? What is the name of the drug? Acetazolamide. And it is going to be drug of choice for mountain sickness. Mountain sickness. Remember, SGLT2 pumps are also present over here. SGLT2 pumps are also present over here, right? This is your SGLT2 pump. Two important things from SGLT2 pump. What is the first thing? What is the first thing? It will be corresponding to which plasma glucose level? कब तक ये पूरा 100% absorption करेगा? Till what time it will be doing 100% absorption? Till the time you are having blood plasma glucose level 180. Okay, and blood plasma 180, and this transport will be 375. Till that time it will be doing what? Reabsorption. This is going to be your renal threshold. Renal threshold. Okay. Okay, tell me, if there is mutation of loop of Henle pump, SGLT2 inhibitor का mutation, SGLT, not SGLT, sodium potassium 2 chloride pump mutation will lead to which syndrome? This is going to lead to Bartter syndrome. Okay, so this is your loop of Henle. Here you will be having 25% of the salt reabsorption, right? And this particular part will be having this sodium potassium 2 chloride pump. What it will do, sir, here urine was going out. This was your urine. Now it will be reabsorbing urine Along with the urine, it will be reabsorbing potassium and chloride also. Here we are having one more pump that is going to be responsible for the absorption of magnesium and calcium, right? Everything will be getting reabsorbed over here, right? Now what is going to happen? This is your this is your sodium potassium 2 chloride pump. So what is going to happen, sir? Everything is going getting reabsorbed. Now what we are doing? We are using drugs like furosemide, torsemide, bumetanide. What is going to happen? This channel will be closed. And if this channel will be closed, the sodium will be going out into the urine. And tell me, if sodium is the beautiful girl going out into the urine, what is going to happen? Sir, pani water bhi kood jayega, no issues. It will also go along with it, right? So this is what is going to happen in the loop diuretics that you are using. The drug name of the drugs are your revise. Keep revising, guys. Exam is so near. Try to answer. Pyrazinamide, torsemide, bumetanide, ethacrenic acid. Right? Ethacrenic acid याद कर लेना. It is a different one, but it is from the same class. Right? If there is mutation, it will lead to a syndrome known as Bartter syndrome. Okay. Next pump that we are having, which is your DCT, distal convoluted tubule pump. In DCT, you will be having same story. You will be having sodium chloride pump. And what is going to happen when you are blocking this pump, sodium chloride pump, there will be overactivation of this calcium pump. So what is the simple thing that will happen? Sir, here they are all working together. If we are blocking this, they are also getting blocked. But here, sir, if we are blocking this, there will be overactivity of this calcium pump. So what is the statement that you want to remember? Loop lost the calcium. Okay, and DCT thiazides that you are using, they are going to reabsorb the calcium. This is the most important thing that you should be using, right? There is your TRPV5 pump, which is responsible for the reabsorption of parathyroid hormone and vitamin D. If there is mutation of this particular pump, what will happen? There will be a syndrome known as Gentleman syndrome. There will be a syndrome known as Gentleman syndrome. Okay, next we are having the collecting duct. In collecting duct, what is going to happen? This is the last part. So here you will be having activity of aldosterone. Aldosterone is coming from which gland? Adrenal cortex. Adrenal cortex, exam question previous year, they have given you the image and asked you which thing will be coming from here, right? So we are having three layers in the adrenal cortex. First one, high yield topic hai. First one, glomerulosa. Second one, fasciculata. Third one, reticularis. Glomerulosa will be releasing what? Mineralocorticoid. ऐसे याद रख लो. You can remember like salt, sweet, and sex, right? Salt will be mineralocorticoid. That is going to be your aldosterone. So first thing you will be releasing aldosterone, that is going to be your mineralocorticoid. Second, it will be releasing what? Cortisol. Cortisol is going to be glucocorticoid, right? And reticularis will be releasing your sex steroids. These are your DHEAs, right? So what is going to happen? Listen to me carefully. Very, very important concept. This is an important concept. Look here. This adrenal cortex will be releasing what? Aldosterone. And this aldosterone has a function. It will make epithelial sodium channel. Epithelial sodium channel. तो क्या इनको ENaC channel बोल सकते हैं? Yes, they are the ENaC channel. And the function of ENaC channel. Sir, sodium channel, same function. Sir, urine was going out. Urine was going out. So they will be absorbing the sodium from the urine, and sir, water will definitely follow. You already know this, and this water will be coming to the blood vessel again. Right? So what is the function of this aldosterone? Is to make ENaC channel, and the function of ENaC channel is to retain sodium and water. Simple understanding. If you keep the simple understanding till the time your body will be having sodium, you know what we are doing? Those people who are hypertensive people, what we tell to hypertensive people? Don't eat salt. What will happen if they are eating salt? So salt has a capability, it will retain water. It will attract water. Every time person is eating salt, you are going to a movie, you are eating what? Salted popcorns or salted chips. What will happen? You need water. You need cola along with it, right? Why? They know about this particular thing. That is why they are selling, right? So this is what is happening, right? You have to use what kind of salt? You can use alternate salt like pink salt, rock salts. Okay, They are having more of potassium as compared to sodium. So sodium ki simple kahani, the simple story of sodium is that whenever there will be sodium, there will be water. There will be water. And aldosterone, what you learned from here about aldosterone, we are having more aldosterone means what? More retention of sodium and water. And if there is more retention of sodium and water, what will happen to the BP? Fluid overload will be there, and because of that fluid, BP will be increased, right? How many cells do we have? Principal cells and intercalated cells. This cell is known as intercalated, this is known as principal cell. Intercalated potassium channel, these are also known as renal outer medullary potassium channels. Okay, sometimes they will refer it like that. Okay, what will happen, sir? Sir, sodium will be coming inside. If it is taking something, it needs to give something, right? So what will happen? It will give potassium, it will give H plus. Potassium is given, H plus is also given. Potassium is going outside, H plus is going outside. This H plus is going to give acidity to the urine. And this potassium is also going to go out, right? Now, if I am giving aldosterone antagonist, spironolactone, okay, what is going to happen? No spironolactone, no aldosterone, no epithelial channels. What is going to happen? There will be potassium not going out. Potassium will be retaining in the body. If the potassium will be retaining in the body, there will be what? Potassium sparing diuretics. So I have given you the mnemonic, that is paste. What is that paste? P for potassium sparing diuretics, A for amyloride, S for spironolactone, T for trimetrine, or E for aplerenone. Okay, second mnemonic I have given you is EAT. E for ENIC blocker, these are your amyloride and trimetrine. Rest will be blocking this particular aldosterone receptor. Okay, if there is increase in the levels of aldosterone, this is known as Conn syndrome. If there is decrease in the levels of aldosterone, Addison's. And if there is mutation of this ENIC channel, which syndrome will occur? Liddle syndrome. You know what kind of mutation is this? This is a gain of function mutation. So what will happen? Lots of ENIC channels will be there. What will happen? Sir, lots of water will be coming. What will be the symptom? Lots of water will be coming, lots of salt will be coming. Wonderful, guys. That will lead to hypertension in the patient. That will lead to hypertension in the patient. Treatments that directly block the ENIC channel blockers, right? Okay, this is done. Lastly, we are having lower part of the collecting duct, and lower part of the collecting duct will be having action of antidiuretic hormone. Now, tell me, from the beginning of the hypothalamus will be having like how many hormones? Eight hormones. Four will be stimulatory. Two will be inhibitory. What else? Two hormone. V for vasopressin. So vasopressin, another name is oxytocin. Tell me, it is getting secreted in the, like it will be formed in the posterior pituitary, right? No. Wonderful. It will be stored in the posterior pituitary, and from posterior pituitary it will be coming. It will be having how many receptors? Three receptors. V1, V2, V3. V1 is present on the blood vessels, esophageal varices. I have told you about the treatment. Name of the drug? Terlipressin. Wonderful. V2 is present on the kidney, lower part of the collecting duct. They are having, which things? Lower part of the collecting duct. Aquaporins. Wonderful. We are having aquaporins. We are having aquaporins. And these aquaporins, these are your V2 receptor. What they will be doing? Sir, they will be retaining water from the urine. A urine is going out, they will only work on water, and they will retain water in the body. If this water is coming into the body, what will happen? Suppose if we are retaining more water, that we will be doing in the cases of SIADH. You know SIADH, what will happen? Sir, SIADH, more V2 receptors will be there. ADH बढ़ गया, ADH is increased, that means V2 receptor will be increased, and the function of V2 receptor is to retain water. So what will happen, sir? These receptor will retain a lot of water, and a lot of water, what is going to happen? There will be a thing known as dilutional hypo, means sodium will be low. Now, sir, only water is coming into the body will be having dilutional hyponatremia. You understand? Dilutional hyponatremia. Okay, you can use hypertonic saline here. You can give other drugs also. What is the drug of choice? If there is increased ADH, there will be a disease known as SIADH. And the drug of choice will be vasopressor antagonist. Vasopressor antagonist, that is your conivaptan or tolvaptan. What about decrease in the levels of ADH? What is going to happen? Decrease in the levels of ADH. Sir, these receptors are decreased. Water is going out. If more and more urine is going out, that is what is known as, more urine going out is known as what? Polyuria. Polyuria. And when do we call it polyuria? What is the cutoff value? More than 3 liters is the polyuria. More than 3 liters is the polyuria. Less than 400 ml is the oligouria. Right? So there will be a thing. There will be, why do we call it diabetes? Right? Polyuria will be there. If the urine is going out more, the patient will be having polydipsia also. Right? Thirst will be increased. Right? He will be having polydipsia. And apart from the polydipsia, phagia center is also in the close extremity. Right? What is going to happen? He will be having polyphagia also. Symptoms of what? Diabetes. But is it diabetes mellitus? No, it is diabetes insipidus. Insipidus can be of two type. Neurogenic problem lies in the hypothalamus or at posterior pituitary or anterior pituitary. Posterior pituitary. Don't make mistakes. Okay. Posterior pituitary, hypothalamus will be making, sending to posterior pituitary, and posterior pituitary will be releasing. So problem lies either in the posterior pituitary, either in the hypothalamus. That is what is known as which type of diabetes insipidus? Central or neurogenic है ना, central or neurogenic. If this particular thing is fine, hypothalamus is working well, pituitary is also working well, but the receptors are not working, that means V2 receptors are having problem, that means kidney is having problem. What do I call it? Nephrogenic. Drug of choice? Central, we can give desmopressin. Here you can give thiazide. Okay, tell me one thing, one more thing. This desmopressin is a drug of choice in the cases of nocturnal enuresis. What will happen in nocturnal enuresis? Bedwetting. Yes, कौन करता है? Obviously बात है बच्चे ही करेंगे, बड़े तो नहीं करेंगे. Right? So those babies who are doing bedwetting, what should be the problem? Sir, this is collecting duct. Listen to me, try to visualize things. Okay, this is the collecting duct. Sir, it will be making urine, it will be going to the ureter, and it will be getting stored in the bladder, and from the bladder it will be going out through urethra. Now what is happening? Sir, we are having more urine in the night time. Baby is feeling like he is standing in the bathroom. Maybe he is able to understand this. Okay, maybe he's even small, right? So usko kya lagega? What baby will feel? He don't feel anything. Let it be. Okay. But the thing is, sir, his bladder is full. That is why he's going for urination. What I can do? I can empty his bladder in the night time. I can give desmopressin. What desmopressin will do? Desmopressin is just like what? ADH. Desmopressin is just like ADH, antidiuretic hormone. It will do what? It will make V2 receptor. It will make V2 receptor. You will be having more V2 receptor. You will be having more water reabsorption from the urine. You will be having formation of concentrated urine in the bladder. There will be no filling of the bladder in the night time. If there is no filling of the bladder, there will be no urge for urination. Baby will not urinate in the night. The drug of choice will be desmopressin. Treatment of choice if they ask you from psychiatry, bed alarms. Done. Next thing. After this, let's talk about the bladder. We are done with the PCT. We are done with the loop of only important things. DCT, collecting duct. Now we are discussing about what? Cystometrogram. So this is the condition of your bladder that is happening inside your bladder. This is a pressure volume graph. This is a pressure and volume graph. What is going to happen? There will be a stage that is known as 1A. There will be first stage that is known as 1A, where what is happening? Can you appreciate? Volume is increasing, pressure is also increasing. Then comes the second stage that is going to be 1B. It is depending on a law. The name of the law will be Laplace law. Laplace law. This was a previous year question, right? So this is going to be your Laplace law. And then what is going to happen? Okay, you are sitting in the class. After urination, you know what is going to happen. Listen to me, a real life example. After urination, you will be having starting of the filling of the urine, right? You will be having increase in the pressure. You will be having increase in the volume. After a certain point of time, what will happen? You will not have the urge to go out. You are sitting right now in the Laplace state, right? You are having what? You are having a limited pressure, and still 1 ml urine is formed every minute. That is filled, right? And it is getting filled. But till the time it will reach around 150 ml. 150 ml, you will be getting the first sensation. You will be getting the first sensation to urinate. And if you are not going, after sometimes what is going to happen? Now volume is not going to increase, only pressure is going to increase, and you will be having a tremendous increase in the pressure. That is mark sensation you will be having around 400 ml. नहीं गए तो यही हो जाएगा, ठीक है? That is going to be your 400 ml, right? So this is what is the condition of your bladder. They have asked you this particular stage is due to what? This particular stage is due to Laplace law, that is going to state that there will be constant pressure, but there will be increase in the volume. आ रही है बात समझ में? Right? First urge you will be having 150, and mark sensation you will be having 450. What is the formula of clearance? Clearance is equal to UV by P. Clearance is equal to UV by P. U is the concentration of the substrate. Simple understanding, keep the simple understanding. C is equal to clearance. So C is the clearance of the substance. U is the urine concentration of that substance. V is equal to urine flow rate. Okay. So how much is going out? What is the flow rate? How much is going out divided by total plasma concentration, right? And this is going to be your C is equal to UA by P. Okay. For GFR estimation, if I want to know, for example, you are coming to me for some kind of surgery, right? And what I will be checking, how can I check whether your kidneys are working fine or not? I can do a test that is known as creatinine. The levels of creatinine are indicative of the kidney story, whether it is working fine or not, right? We can also do one more investigation, that is your technetium 99 DTPS scan, right? Okay. Then we are having what? JG apparatus. They have asked you all of the following are the component of JG apparatus except. Okay. So what are the three components will be there? First is JG cells will be there. JG cells से क्या निकलेगा? Renin will be released. Okay. Second is your macula densa will be there, which is a GFR sensor. And third cell we are having is mesangial cells. Mesangial cells. Okay. So these are the three cells we are having. Renin is secreted. What this renin is going to do, we will understand. Second, GFR sensor we are having, they will be releasing what? Adenosine. Remember, adenosine is responsible for the contraction of afferent arteriole. And if the afferent arteriole is getting contracted, what will happen? So definitely blood flow to the kidney will be decreased. If the blood flow to the kidney will be decreased, that means the GFR is decreased. Okay. Mesangial cell contraction will lead to decrease in the GFR. Mesangial cell contraction will lead to decrease in the GFR because they will be releasing two things. First is your endothelin, universal constrictor, endothelin. Pulmonary hypertension, you are always studying about. Pulmonary hypertension, the drug of choice will be endothelin antagonist. What is that? Bosentan, endothelin antagonist, bosentan. Okay, what you are doing in pulmonary hypertension? First, one more thing that you are doing. Pulmonary hypertension, there will be constriction of the vessel, right? Constriction of the vessel, what you will be giving first line? This is a calcium induced vasoconstriction. Remember, we have discussed how it is happening, right? So first of all, we are giving CCB, calcium channel blocker, calcium induced hypoxia, I have told you, right? So first thing we will be giving CCP, then we can give what? Sildenafil, yes, nitric oxide. We can increase nitric oxide. And third thing, the drug of choice will be bosentan. And one more thing, PGI2 analog, iloprost, right? Iloprost. Angiotensin 2 is also responsible for the vasoconstriction. Relaxation ke liye, you already know there are two things. One is nitric oxide. Second one is your atrial natriuretic peptide. Atrial natriuretic peptide is coming from the walls of atria. It will be doing natriuresis. That means salt is going out of the body. It is a peptide hormone that means it is generated inside the body. So whenever your heart will be feeling more pressure, हार्ट के ऊपर मोर प्रेशर पड़ेगा, what it will do, it will release atrial natriuretic peptide, and this is going to release sodium from the body, from the kidney. If sodium will be gone from the kidney, what will happen? And water will be gone. If water will be gone, what will happen to the BP? What is BP? Pressure exerted by blood on the wall of the vessel. This is BP. right? The more water you or the more blood you will be having, the more BP you will be having. So what you can do, you can decrease the level of blood, but you cannot technically decrease the blood, but you can decrease the level of plasma, because blood will be having 92% of the, means 60% will be plasma, right? And 92% will be water. So you can easily deal with the water. So what you would like to do, you would like to decrease the water whenever you are having hypertension. Whenever you are having hypertension, what do you want to do? You want to decrease the water. Either you want to decrease the water, either you want to dilate the vessel. This is what you can do according to me, right? Okay, look here. So this is what it is. If your brain will be having edema, if your brain will be having edema, brain will release what? Brain natriuretic peptide. They are going to dilate the vessel. Same story. They are going to do what? They are going to remove the fluid from the body. You will be having decrease in the intracranial tension, right? Now, this is the most important system that you have to remember. Liver is releasing what? Liver is releasing what? Angiotensinogen. Angiotensinogen is getting converted into angiotensin with the help of renin. Everyone tell me, renin is coming from which cells? Juxtaglomerular cells, right? Now this angiotensin 1 is going to get converted into angiotensin 2, and this angiotensin 2 will be having converted conversion because of angiotensin converting enzyme, and these converting enzymes are the binding receptor for COVID-19. These ACE receptor are the receptor for the binding of spike protein also, right? So what is going to happen? This angiotensin converting enzyme is going to convert angiotensin 1 into angiotensin 2, or ye angiotensin 2. This angiotensin 2 is now going to work at how many receptors? Two receptor. One is present on the blood vessel. Second is present on the adrenal gland. That is your aldosterone. That is your aldosterone will be released. Now you will be telling me the function of aldosterone. Sodium and water retention. Sodium and water retention. Okay. And this blood vessel you will be having. Blood vessel के अंदर क्या कराएगा? Vasoconstriction. That will lead to increase in the BP. So first of all, if I simply ask you the function of renin, the function of renin is what? Increase in BP, increase aldosterone. So this aldosterone is going to do what? Increase in sodium and water. So can I say renin will increase BP, renin will increase sodium and water retention in the body? And these are the major causes for what? Hypertension, isn't it? Right? So these are the major causes for hypertension. We can treat hypertension because we already have done, right? So we can use ACE inhibitor, we can use ACE inhibitor, we can use ARB. We can use ACE inhibitor, we can use ARB. I can block this. What will happen? Sir, angiotensin 2 will not become, right? Second thing, I can directly block the receptors of angiotensin receptors, right? So what will happen? There will be decrease in the BP. Beta blocker, I will be teaching you. Okay, C4, calcium channel blocker. What I have told you, calcium is responsible for two things, right? In the in the vessel, it will be responsible for vasoconstriction. In the muscle, it is responsible for muscle contraction. In the cells, it will be responsible for exocytosis. Okay, so I can do calcium channel blocker, and that is going to help me in the central part in the heart. What are the calcium channel blocker we can use? Two only: diltiazem, verapamil. In the periphery, we can use dipines, any dipine. We can use amlodipine, nifedipine, right? D4 diuretics that we have already discussed. The ultimate function of diuretic is what? To remove sodium from the body. Loop diuretics, removing sodium from the body. DCT, thiazides, removing sodium from the body. Okay, collecting duct, removing sodium from the body. Till the time sodium is going out from the body, what is going to happen? ये तुम्हारा लड़का, water is also going behind the sodium, right? What is going to happen? Sodium out, water out, fluid will be low, BP will be low. Do you understand this? Okay, so to decrease BP, we are having this four things. D4, you can again remember dilatation of the vessel, and that you can do with the help of vasodilatory things. That is going to be nitric oxide, vasodilation, hydralazine, right? All these things you will be studying in. I'm just giving you a short history, right? Beta blocker, I will be teaching you. So let me teach you. Beta receptor कहाँ होते हैं? What is the location of beta receptor? Heart and किडनी, हार्ट एंड किडनी। हार्ट में तीन ही चीजें पड़ी है, वी हैव डिस्कस्ड ओनली थ्री थिंग्स इन द हार्ट। व्हाट आर दोस थ्री थिंग्स? फर्स्ट इज एसए नोड, second is AV node, third is muscle. In the kidney, we are having GG cells releasing what? Renin. And renin की कहानी बता दो, what this renin is going to do? It is going to increase. It is going to, like, tell me the story. It is going to do what? It is going to convert angiotensin into angiotensin 1. Angiotensin 1 is going to convert into angiotensin 2 with the help of which enzyme? Angiotensin converting enzyme. And now this angiotensin 2 will be having how many receptor? Bachche? Two receptor. One is present on the blood vessel causing vasoconstriction. Second is present on the kidney. Second is present on where? Adrenal cortex. Releasing what? Adrenal cortex will be having how many parts? Three parts. G, F, R. G is responsible for aldosterone. Aldosterone will be coming from adrenal cortex going to which part of the kidney? Adrenal. It will be coming, and it will be coming to which part of the kidney? Collecting duct. Upper part, lower part of the collecting. Upper part. Lower पे ADH, upper पे अपना ये, ठीक है? It will be coming to the upper part. In upper part, aldosterone has come. It will be making what, बच्चे? So epithelial sodium channel. Sodium channel has a function to retain water. Water will be coming inside. What should be given outside? Potassium and H plus. कहानी बन रही है, potassium बाहर जा रहा है, H plus is also going out, right? Now what is going to happen? This water is going to get accumulated in the body. This sodium is also going to get accumulated in the body. What will happen? Increase in the fluid overload, right? Fluid बढ़ेगा. If the fluid overload is there, blood pressure will also overload, because it is what? Pressure exerted by fluid on the wall of the vessel. That is what is blood pressure. You understand? Renin is increasing BP. Okay. These two things, SA node is getting activated. What will happen to the conduction? What will happen to the conduction? Say nothing. Say nothing. Right? What I've told you. SA node is always concerned with the heart rate. Heart rate. Okay. इसका कहीं कोई मत जोड़ना, ठीक है? AV node is always concerned with the conduction. Muscle is always concerned with the contraction. This effect is known as chronotropic effect. This effect is known as dromotropic. INO for contraction. IN are required for contraction. This is known as inotropic effect. This is how they will be confusing you. They will not write heart rate will be increased. They will be writing increase in chronotropy. What you will understand, increase in chronotropy means what? Increase in heart rate. They want to know the simple thing, but they just want to check your knowledge, right? You understand this? Done. So beta 1 done. Let's discuss about the beta 2 also. Beta 2 is responsible for what? Bronchodilation. Beta 2 is responsible for what? Bronchodilation. Alpha 1 is responsible for what? Vasoconstriction. Alpha 2, let it be. It will be acting as a brake. Okay. It will be acting as a brake. So alpha 1, alpha 2, beta 1, beta 2. These are the important. Beta 3 is also there. That is, beta 3 is also there. Beta 3 is responsible for lipolysis. Drug is mera background, right? So we are done with this also. You want a break? Okay. Listen to me. Just give me a moment. इसमें रैपिड रिविजन में भी ब्रेक होते हैं क्या? How we are able to complete? We will be completing in like next 3 hours. You would like to go out? Okay, 10-15 मिनट में जाना, थोड़ा सा पढ़ा लेने दो. खाना? No खाना. Sit down, guys. Sit down. Sit down. Wait. Okay. Sit down. Let me complete the थोड़ा सा ANS पढ़ा लेते हैं, फिर चल जाना. Okay. Let me discuss about the autonomic nervous system. I will give you the break. Don't worry. Sit down. Keep quiet. Okay. We have to cover it up because other students are also there online and they are having other class also, right? So we are having autonomic nervous system. Okay, tell me, what are the parts of autonomic nervous system? Yes, parasympathetic and Sympathetic. What is the neurotransmitter of parasympathetic nervous system? अरे सब्जी मंडी मत बनाओ, शांति से बैठे रहो, ठीक है. What is the neurotransmitter for parasympathetic nervous system? So if the neurotransmitter is acetylcholine, can I also call it a cholinergic nervous system? Yes. Can I also call it cholinergic system? Yes. So this is your cholinergic system. If the neurotransmitter is acetylcholine, I can also call it cholinergic nervous system. In exam, you will be getting question not like this. They will be giving you parasympathomimetic effect. Mimetic say what you will be remembering. It is doing the mimicry. Parasympatholytic means what? This is sympathetic nervous system, है ना? Parasympatholytic. What does it mean? हो गया मोए मोए. This is going to be anticholinergic system. This is going to be anticholinergic nervous system, right? So let me give you the examples. Okay, mimetic will be this one. Okay, how many receptors do we have? Muscarinic, nicotinic. Parasympathetic nervous system will be having muscarinic receptor. It will be having nicotinic. Nicotinic can be neuronal, or it can be neuromuscular junction. Neuromuscular junctions पे जो होंगे neuromuscular, right? Muscarinic receptor, what we have studied, कितने होते हैं बच्चों? Wonderful. 2 नहीं होता, M3 होता है. M1, M3, M5, M2, M4, right? So whenever you are smoking, let's take example of smoking. What is going to happen? M1 is responsible. These three are GQ type of subunit. What is where it will be present? It will be present where? पहले तो ये बता दो. GIT. M3. Tell me the location. First one. Eyes. मैं ही नहीं बताऊंगा, तुम बताओ. Salivary gland. वो. Next. Bronchus. GIT. Bladder. Okay. M5 will be present in CNS. M2 present GQ or GI G0. Sorry, GI G0, not GQ. Okay. M2 will be present at two places on the heart. What is this two places? SA node, AV node. Wonderful. SA node, AV node, not on the muscles. Okay. Now I will be talking about the poisoning, organophosphate poisoning. उससे पहले अंडरस्टैंड व्हाट इज द नॉर्मल फंक्शन. अगर किसी को नहीं आता है तो देख लो, समझ में आ जाएगा. सो दोज पीपल हु आर स्मोकिंग, जो सिगरेट पीते हैं उनके साथ में क्या होता है, ऐसे समझो तब समझ में आएगा तुमको, ठीक है. सो दोज पीपल हु आर स्मोकिंग, व्हाट विल हैपन टू देम? When they are smoking, parasympathetic nervous system will get activated, है ना? Right? Parasympathetic nervous system will get activated. They will be having increase in cognition. First thing, increase in cognition. Okay, the brain power will increase, right? Second thing, wonderful. We will start. नहीं, don't start. Those who are smoking, quit कर दो, ठीक है? Enough time is there, right? So GIT, what is going to happen? There will be M1 receptor. Can anyone tell me M1 blocker drugs? M1 blocker. Yes, someone is saying very good. That is pyrinzapine and telenzapine, right? In your eyes, what it is going to do? Sir, simple understanding. GQ का मतलब होता है, the meaning of GQ is what? Contraction. And M1, M3, M5 will be contracting. Okay, so whenever you are smoking, what is going to happen? Not just smoking, anything which is going to activate your parasympathetic nervous system, you will be having same effect. Okay, so what is going to happen? Whenever salivary gland is contracted, what will happen? Salivation, increase in salivation. Bronchus will be constricted. Bronchoconstriction. GIT will be constricted. Increase in peristalsis. That is why these people are taking in the morning cigarettes, right? They will be taking cigarettes in the morning because it will increase their peristalsis, right? In the bladder, they will be having what? Contraction, contraction. Wonderful, guys. Contraction, right? What will happen to their SA node? सर बहुत एंजाइटी हो रहा था, बहुत पाल्पिटेशन हो रहा था, एक सिगरेट पी लिया, इट इज डन नाउ. यस, पाल्पिटेशन विल इंक्रीज और डिक्रीज? अरे पहले ये बताओ, फर्स्ट ऑफ ऑल टेल मी व्हाट इज पाल्पिटेशन? फीलिंग ऑफ own heartbeat. It's not a feeling. I'm asking physically what it is. It is the, listen to me, it is the excessive contraction of cardiac muscles. Okay, feeling of heartbeat is fine, but it is the excessive contraction of heartbeat. It is the excessive contraction of cardiac muscle. If excessive contraction of skeletal muscle, we call it what? What is this? ये सिंपल है ना, कार्डियक का एक्सेसिव कॉन्ट्रैक्शन पाल्पिटेशन है, ये ट्रेमर्स है, ये ट्रेमर्स है, ठीक है। और इसके बाद में, चलो छोड़ो। आ आ जाओ, we have limited time, like we cannot do much of the things. Okay, most important things we will be doing. Okay, in CNS what is going to happen? It is going to, CNS there is not much effect. SA node, what is going to happen? SA node, it is going to increase or decrease heart rate? Crease, what is crease? बढ़ेगा कि घटेगा? अभी भी गपला कर रहे हो। How many says it will decrease? Raise your hand. How many says it will increase? बढ़ेगा? डिक्रीज। ऑनलाइन वाले भी डिक्रीज बोल रहे हैं, मान लो चलो डिक्रीज होगा, बिकॉज इट इज GI और G0 सब टाइप यूनिट, सो इट विल डिक्रीज योर हार्ट रेट, इट विल डिक्रीज योर conduction, it will decrease your heart rate, it will decrease your heart rate, decrease your conduction. Decrease in heart rate is also known as bradycardia. Arrhythmias are a different story, don't connect it here, right? Arrhythmias are different, cardia is different, right? Bradycardia will be there. If there is decrease in conduction, current from the above chamber is not going to the below chamber. What is this disease? Heart block, AV block. The current from the above chambers is not able to go to below chambers. There will be no better contraction. This is known as AV block, right? So this is going to be block, right? So this is going to be the things you will be having during smoking. Smoking is going to do what? These changes. It will increase your cognition. It will increase your secretions in your GIT, M1 secretion, acid secretion will be increased. That is why we are having what? Smoking induced ulcer. Those people who are smoking, what is going to happen? M1 is going to activate, it will activate acetylcholine in the parietal cell. I hope you can connect, right? And this is going to increase what? HCl. This is going to increase HCl, and this is the HCl which is going to cause what? Ulcers. This is what is going to cause ulcers. Second mechanism is also there, but no need to go into detail. But look here, right? Eyes, you will be having what? Meiosis, salivary gland salivation, bronchoconstriction, peristalsis, contraction. Now, let me ask you a question. If there is a patient who is coming to you with the symptoms, let me give you the symptom. What are the symptoms? Organophosphate poisoning ka patient. What are the symptoms he will be having? First of all, you are the emergency doctor. You are sitting in the hospital. Patient is coming on a stretcher. What are the things you will be seeing in this particular patient? First of all, start from the head. Try to look how you will look at the patient. Start from the general appearance. Start from the head. You will be looking at the eyes. In the eyes, you will be having what kind of pupil? In the question you will be getting pinpoint pupil. Pinpoint pupil, that means what is happening, sir? Parasympathetic overactivation leading to what? Meiosis. Second thing, sir, what other symptoms apart from pupil, sir? Salivary gland contracted. Salivary gland contracted, he will be having drooling of saliva. Drooling of saliva. Third thing, bronchus constricted. Bronchus will be constricted, he will be having problem and difficulty in breathing, right? Apart from that, sir, GIT contracted, acid will be released, peristalsis will be more. More peristalsis means what? He will be having defecation. You will be finding the patient ke kapde gande ho rakhe. Okay, he will be having defecation. Apart from that, sir, bladder will get contracted. He will be having urination. You will be able to identify this patient. Is this patient is going to die because of defecation or urination or something else? No, this patient is going to die because of decrease in heart rate, that means bradycardia, and decrease in conduction, that is known as AV block. These are the important things. Respiratory bronchoconstriction is also there, but this is the main thing that is going to happen. Because of this, patient is going to die. Okay, you give me the treatment. What is the treatment, sir? These are all cholinergic systems. Wonderful, wonderful. Online people are also giving me the answer. Good answer, right? So this is the treatment. Treatment will be anticholinergic. And what is the anticholinergic? If I ask you the drug of choice for bradycardia with AV block, Bradycardia with AV block, always give atropine. Okay, bradycardia, a patient is coming to you, with bradycardia, decreased heart rate, AV block. Patient is having AV block. What kind of ECGs? Can you appreciate ECGs? Yes, you can identify. Okay, so yes, what you will be finding? Increase interval or segment? Segment guys, segment. Okay, P के बाद में segment बताया था, that would be having increase in the segment, type 1, type 2, Mobitz 1, Mobitz 2 or type 3. Okay, I think you can understand that. Okay, so you will be having this bradycardia you can easily identify, heart rate you can easily identify, you can check the ECG of this particular person, you will be able to make diagnosis now. Are you able to make diagnosis, getting confidence? है ना? ठीक है, what is the drug you will be giving? You will be giving what? Organophosphate poisoning. The treatment of choice will be, sir, it is an anticholinergic drug which is going to block these two things. What atropine is going to do? Anticholinergic will be having all the opposite effect. Okay, whatever we have learned here, this is the cholinergic thing. Opposite will be, sir, anticholinergic thing. Okay, let me ask you one more question, then we will be discussing about that. That is going to be your datura poisoning. Datura is also known as stro स्ट्रोमोनियम. क्या नाम है धतूरा का? कैलोट्रोपिस. कैलोट्रोपिस आंकड़ा होता है, आंकड़ा. कैलोट्रोपिस इज आंकड़ा, राइट? धतूरा इज अ डिफरेंट थिंग. हैव यू एवर बीन टू लाइक मंदिर? थॉर्न एप्पल. Thorn apple with the thorn, multiple thorn, green color thing, right? That is the most common roadside poison that you are using. 100 seeds are the fatal dose, right? These are all questions they have. So, Dhatura is important, right? है ना? So, what the people are doing, Dhatura is an anticholinergic thing. Listen to me, look here. Dhatura is an anticholinergic thing. They are taking out the seeds, they are mixing it with the sweets. And those sweets, if you are eating, what will happen? Those sweets, it is known as most common roadside poison. Those sweets you are eating in bus, you are eating in train. What will happen? इसलिए तो घर वाले बोलते हैं, don't take sweets from anyone. Not just sweets, don't take food from anyone. Right? What will happen? Let's try to understand. Look here. First thing, there will be decrease in the cognition. Cognition is what? Cognition is the filter. Cognition is the filter, right? You must have seen in the movies what happens when they are injecting something. What will happen? They are injecting anticholinergic thing. What will happen? Truth serum, scopolamine. What will happen? Decrease in the cognition. Cognition decrease. He will be telling बम कहाँ लगाया है, पैसे कहाँ छुपाए हैं, गड्ढा कहाँ खोदा है. Everything they will be telling without the filter. You must have seen that, right? So what they are doing, they are basically blocking the M1 receptor. Decrease in cognition means you are telling without filters, right? So now thief will be giving you the sweets and he will be asking जल्दी बता पैसे कहाँ रखा है, right? You will be telling उस pocket के अंदर रखा हुआ है, right? And you will be telling everything, right? Because now you cannot lie, right? You will be telling everything. Second thing, what is going to happen? It is going to increase your it is going to decrease your M1 receptor, leading to what? Constipation. Leading to what? Constipation. What happens about the meiosis? Here you will be having mydriasis. Because of mydriasis, are you able to see that particular person? Pupils are dilated. You are not able to identify that person, right? You will be having what? You will be having decrease in salivation. You will be having bronchodilation. You will be having decrease in peristalsis. You will be having decrease in muscle bladder contraction, detrusor bladder contraction, right? But you will be having increase in the heart rate, increase in the conduction. You will be having tachycardia. You will be having more conduction. You understand this, right? So anticholinergic poisoning can be there. Cholinergic poisoning can be there. Dhatura, atropine, belladonna, all these things are working on the same principle. Same principle is what? Anticholinergic principle. They will be giving you this particular thing. You are not able to identify who was the person, and you will be telling what you have, right? Nowadays. Okay, now we will be having like sympathetic. We have already done sympathetic. Major thing, the neurotransmitter will be adrenaline. Neurotransmitter will be adrenaline, noradrenaline, or dopamine. Dopamine. What are the receptors that we are having? Alpha 1, alpha 2, beta 1, beta 2. These two we have already seen. These two we have already seen, right? Tell me, what is the drug of choice for cardiac arrest? Adrenaline, because it is going to work for A for adrenaline, A for all the receptor. Okay. कार्डियक अरेस्ट में क्या होता है, पेशेंट चलते चलते एकदम से गिर गया, पार्क के अंदर कोई अंकल गिर गए, हार्ट नहीं चल रहा, हार्ट इज नॉट वर्किंग, lungs are not working, what you will be giving, you will be giving CPR, cardio pulmonary resuscitation. Cardio sir, we can use adrenaline. Cardio, we can remember beta 1 is the cardio sir, beta 1 is working on the heart, beta 2 is the pulmonary sir, it will be working on the lungs, right? Heart में three things, it will increase your SA node, it will increase your AV node, it will increase your muscle, right? It will be increasing your renin as well. And renin, we have already seen, sir, it will be activating aldosterone, increasing sodium and water retention, and it will also cause vasoconstriction. You understand this? I hope you understand this. Okay, bronchus, it will be causing bronchodilation, so that air that you are giving, it will be reaching to the tissues, right? It will be reaching to the organ. That is how we are going to resuscitate this patient. Can you use atropine in this patient? Yes. If adrenaline is not working, we can use atropine. Why? Because sir, atropine is also increasing heart rate and conduction, right? So we can give it as a add-on, right? You can take a break for like 15 minutes and we will continue after that.